The first is Dr. Saji Kumar, then Vincent Rajkumar, then Sagar Lonial, and Dr. Ajay Kumar Nuka will be talking on the different aspects of the multiple myeloma. On behalf of Indian College of Hematology, which is the academic wing of Indian Society of Hematology, today is the 5th virtual CME on multiple myeloma, which is being conducted by Indian College of Hematology. At the outset, I extend my sincere thanks to Dr. Saji Kumar for doing everything for organizing this wonderful CME, and moreover, accepting the responsibility and account. And it's a really great privilege. He agrees to be the overseas advisor of Indian College of Hematology. And also, I extend my sincere thanks to our international faculties like Vincent Rajkumar, Dr. Sagar Lonial, and Dr. Ajay Kumar Nuka on behalf of from Indian College of Hematology for agreeing and sparing very difficult time because it's very early morning in US. So with these few words, I request Dr. Saji Kumar to take over these proceedings to discuss or to complete this CME on multiple myeloma. Dr. Saji Kumar, please.
Hey, good evening, Dr. Jaina. Thank you so much for the opportunity to be here this morning. You know, I'm hoping that the next 2 to 2.5 hours, we can discuss some of the most important aspects about managing monoclonal gammopathies with a focus on multiple myeloma. The other faculty members this morning are going to be, as Dr. Jaina mentioned, Dr. Vincent Rajkumar from Mayo Clinic, Dr. Sagar Lonial from Emory University, and Dr. Ajay Nuka also from Emory University. They should all be joining here soon. But again, welcome and thank you for being here this evening, for you, morning for me. I'll go ahead and get started with the first talk. What we are hoping to do today is to talk about the diagnosis and response monitoring in monoclonal gammopathies, followed by a talk focused on the precursor conditions, monoclonal gammopathy of undetermined significance and smoldering multiple myeloma, which will be followed by Dr. Lonial talking about the newly diagnosed multiple myeloma. And then Dr. Nuka and I will talk about the current approach to relapsed multiple myeloma, followed by a discussion on some of the emerging agents. I would like to encourage all of you to ask questions. Please put the questions in the chat box if need be, or ask as we go into the Q&A session. So with that, I will get started with my first talk here. Let me try and share my screen. Is everyone able to see this? Okay.
Yes, sir.
All right, perfect. So these are my disclosures. Now, when you think about monoclonal gammopathies, it's a huge spectrum of disorders, ranging from the most common one, which is monoclonal gammopathy of undetermined significance, to very rare monoclonal gammopathies, including Poem syndrome, Schnitzler syndrome, and a variety of others, which are very, very uncommon. It is reasonable to say that the over 90% of monoclonal gammopathies in the community is probably going to be monoclonal gammopathy of undetermined significance. Even in a referral center like Mayo Clinic, nearly 57% of patients have monoclonal gammopathy of undetermined significance. And the next most common condition that we encounter in the clinic obviously is multiple myeloma, followed by glycogen amyloidosis and a variety of other monoclonal gammopathies. And it is very critical that we make the right diagnosis for patients for 2 important reasons. One, we need to have a definite diagnosis and distinguish the condition from monoclonal gammopathy of undetermined significance, because that determines whether you're going to treat the patient or not. And the second most important aspect is obviously classifying the particular diagnosis, so that because the treatment approaches can vary somewhat. So I would think about it as 3 essential steps. One is establishing the presence of a monoclonal plasma cell process in the first place, because that is the fundamental piece that we need for making a diagnosis of monoclonal gammopathy. Second is to classify the monoclonal plasma cell process into that where in the spectrum of monoclonal gammopathies they lie. And then finally, we need to do staging and risk stratification in order to make treatment decisions for these patients. Now, for making the diagnosis of a monoclonal gammopathy, there are 2 critical pieces. One is you have to have a monoclonal protein either in the serum or urine, and or you have to demonstrate presence of clonal plasma cells somewhere. So how do we detect the monoclonal protein? The traditional approach has been to use serum protein electrophoresis, which, as you can see on the left-hand side, can demonstrate a spike in the typically in the gamma region on the electrophoresis that we refer to as the M spike or the monoclonal spike, which stands up in comparison to kind of the broad band that we see in the normal patient. But that gives us a quantitative estimate of the monoclonal protein size. But we also need to do what we call an immunoelectrophoresis or immunofixation, which allows us to identify the specific type of monoclonal protein. In this particular setting, it is a IgG kappa monoclonal protein based on the discrete bands that you can see with antibodies against the G heavy chain and kappa light chain. Now, it's changing. Now, unfortunately, not every patient will have a intact M spike immunoglobulin that can be detected on the serum protein electrophoresis, and about 15% of patients might only secrete a light chain, kappa or lambda, and not the accompanying heavy chain. And in those patients, we can use a serum-free light chain assay that recognizes an epitope that is typically on the light chain that is typically hidden when they are in combination with the heavy chain. And so we can use this assay to not only to estimate the amounts of kappa and lambda free light chain, and using the ratio, we can decide whether there's a monoclonal process or not. Now, more recently, we have been using mass spectrometry as a way to detect monoclonal protein, and we think it is about a log more sensitive than immunofixation for detecting the presence of a monoclonal protein. In this particular setting, either serum or urine sample undergoes immunopurification, and then they are spotted on a moldy plate, undergoes tandem mass spec, and then we use the spectral overlay and analysis in order to identify the presence of a monoclonal protein spike. And as I said, this is certainly a lot more sensitive than the traditional immunofixation. Now, ongoing work is going to be targeted towards using this method for quantification of the monoclonal protein as well. And hopefully in the near future, we will be basically changing over to entirely a mass spec based approach for detecting monoclonal and quantifying monoclonal protein. Now, what about the myeloma or the monoclonal plasma cells? Now, typically they are found in the bone marrow, as you can see on the left-hand side. These are eccentric cells with eccentric nucleus, and obviously an extensive cytoplasmic, what we call a HOF, that represents endoplasmic reticulum that is filled with monoclonal proteins. But not only in the bone marrow, we can also detect this in the peripheral blood, especially if we use highly sensitive flow cytometric techniques. We can actually detect circulating plasma cells in over 80% of patients with newly diagnosed myeloma. And then in some patients, in addition to the bone marrow or in isolation, patients might present with a plasmacytoma, which typically represents a collection of monoclonal plasma cells, as you can see on that CT scan. And on the biopsy, you see sheets of clonal plasma cells. Now, if your objective is to screen for a monoclonal protein, right? So you have a patient in the clinic in front of you where you want to see if there is a monoclonal protein. Typically, you can do a serum immunofixation, which will detect 93.5% of these patients. You can do serum electrophoresis, which detects a monoclonal protein about 80%. But if you were to do a serum protein electrophoresis with immunofixation or serum-free light chain assay, 99.5% of the patients you can demonstrate that there is a monoclonal protein in patients who actually do have a monoclonal process. So it's a highly sensitive approach to detecting monoclonal protein if you're suspecting a monoclonal plasma cell process. Now, if your clinical differential also includes patients with amyloidosis or other monoclonal gammopathies of renal significance, then certainly you want to do a 24-hour urine protein in addition to the blood tests. Now, if you were to use a mass spec based screening assay, and this is a study that was done using the Olmsted County cohort, looking at the difference between a mass spec-based approach and a traditional serum protein electrophoresis-based approach. And you can see that you can almost detect 50% more patients with a serum-free, with the mass spec-based approaches. Now, in terms of, so when you make the diagnosis of plasma cell disorders, one thing you need to keep in mind is, as I previously mentioned, it's a broad spectrum of disorders. Obviously, the common ones we see in the clinic are on the left-hand side, the monoclonal gammopathy of undetermined significance, smoldering myeloma, active multiple myeloma, amyloidosis, and Waldenstrom. And obviously, we have less common conditions. We won't go into too much of detail today, but Dr. Rajkumar will be talking about this after my talk, especially the monoclonal gammopathies of renal significance. And again, the buggers and smoldering myeloma, I'll briefly touch upon the diagnosis, and then Dr. Rajkumar will take up on these topics in more detail after my talk. So the precursor conditions typically include the monoclonal gammopathy of undetermined significance and smoldering myeloma. These two precursor stages are differentiated by the amount of monoclonal protein and the plasma cells. So it's essentially a quantitative difference between these two. And of course, both these conditions are associated with no myeloma defining events or presence of amyloid or other conditions associated with end organ damage. Now, there is this entity of light chain muggers that also been described in the past decade. And these are patients who have an abnormal free light chain ratio, but when you do an electrophoresis, you don't really identify a heavy chain that is associated with the monoclonal process. And these patients, again, as with muggers, do not have an end organ damage, and obviously meets the other criteria for muggers as well. Now, in terms of diagnosing active multiple myeloma, there have been some changes in the past decade, primarily in our pursuit to identify patients before the end organ damage happens. And this is important because the end organ damage in some patients can be renal failure that cannot be reversed or neurological damage that cannot be reversed. So there's a lot of interest in trying to identify patients before something catastrophic like that happens. Obviously, it's a fine line between screening somebody for a monoclonal process versus distinguishing between a precursor condition and active myeloma in somebody whom you have already diagnosed a monoclonal process. So in the past, we have used the CRAP features, which you're all very familiar with. Obviously, this represents the end organ damage already being there. But in the a few years ago, Dr. Rajkumar and others actually updated the diagnostic criteria by including 3 characteristics. One is a clonal plasma cell percentage of 60% or more, an involved free light chain ratio of more than 100, or more than 1 focal lesion on MRI studies. These 3 characteristics actually predicting an 80% or more risk of progression in 2 years. Now, it is important when you apply this criteria to take the clinical context. In particular, we have recently demonstrated that patients with a high free light chain ratio, if they are not spilling any of these free light chain in the urine, the risk of progression may not be as high as what we had originally thought to be. So what do we do for a workup? Obviously, there are diagnostic part of the workup as well as the prognostic aspects of the workup. The diagnostic aspect, obviously, as we just talked about, is focused on obviously demonstrating the monoclonal protein, demonstrating the monoclonal plasma cell process, and looking for end organ damage in order to make that distinction between precursor conditions and the other conditions that require therapy. So serum protein electrophoresis, 24-hour urine protein electrophoresis, both with immunofixation and serum-free light chains, complete blood count, complete chemistry, including calcium and creatinine, a whole body low-dose CT or a PET CT should be considered as integral part of the diagnostic workup, because this obviously will play an important role in distinguishing between myeloma and precursor stages. In patients with no abnormalities on this, and you are really thinking of trying to make the distinction between active myeloma and smoldering myeloma, an MRI of the spine would be extremely useful. And also an antiprobe can be quite valuable in these patients to rule out underlying cardiac amyloid, which is something which, if missed, can be quite catastrophic for the patients. Then there are obviously the prognostic aspects of the workup, which include the serum LDH, beta-2 microglobulin, and albumin, all of which are required for the ISS staging system. The bone marrow should be subjected to FISH studies, which will allow us to, again, identify the high-risk cytogenetic abnormalities which goes into the revised ISS staging system, as well as the newly described staging system like the Mayo additive staging system. There are additional aspects that are not very commonly used but can be quite valuable, which are the presence of circulating plasma cells, high plasma cell proliferation, and certain plasma cell phenotype, all of which can have prognostic value. And more recently, there have been a lot of mutation panels and next generation sequencing and RNA expression panels, which can all be used for prognostication as well. Now, additional workup may be needed in certain situations. Obviously, if somebody presents with renal insufficiency with very high free light chain, and you know it's an acute onset renal insufficiency, it can be safely assumed that we are dealing with Cas nephropathy. But if in case someone has renal insufficiency with low light chain levels, a renal biopsy is warranted, as is the case with someone with significant albuminuria. Tissue biopsy is called for when you suspect plasmacytoma and no other clonal plasma cell population is identified. In patients with suspected amyloidosis, organ-directed biopsies can be quite beneficial in establishing diagnosis. Patients with peripheral neuropathy can be subjected to the EMG studies, and obviously those with suspected amyloidosis or history of heart failure should undergo an echocardiogram, and so should patients before certain therapies if they are that are known to be cardiotoxic. Now, what about solitary plasmacytoma? Now, this is another area, again, not very common, but it's important both from a initial diagnostic standpoint to distinguish this from active myeloma, and also in terms of subsequent follow-up for evidence of disease progression. So essentially, it's defined as a solitary lesion in the bone or soft tissue with clonal plasma cells, obviously a normal imaging studies, and absence of end organ damage. And you can certainly have some solitary plasmacytomas with minimal marrow involvement, where you have less than 10% plasma cells in the bone marrow. Obviously, if you have more than 10%, then we are talking about a diagnosis of multiple myeloma in the presence of a bone lesion. So from a clinical presentation, obviously, there are certain situations where you think about monoclonal gammopathies in the differential diagnosis. One of them is in patients who might present with renal insufficiency. And again, this includes, again, a slew of different conditions. It could be Cas nephropathy, patients with amyloidosis, light chain deposition, and monoclonal gammopathies of renal significance, all of which needs to be kept in mind. Amongst those patients who present with neurological conditions, again, cord compression due to a plasmacytoma, amyloidosis, POEM syndrome, neuropathy associated with monoclonal gammopathies, these all should be kept in mind as well as part of the differential diagnosis. And obviously, the spectrum of renal disorders can be quite wide, and I won't go into all the details, but there's this nice article that was published by Dr. Sanjeev Sethi from our group quite a few years ago that have gone into some of the variety of different renal conditions that can be associated with monoclonal proteins. And it's very important, obviously, in this setting to understand that connection, because the treatments can be quite different for these patients with or without associated monoclonal gammopathy, and the outcomes can be quite different as well. Myeloma Cas nephropathy is something we are already quite familiar with, and obviously results from the binding and co-aggregation of those excess free light chains with the TAM horsefall protein. It clogs up the tubules and typically is associated with very high levels of light chain. You do a kidney biopsy, you can find these tubules that are blocked with the light chains, and on immunofluorescence, they would be light chain restricted. Now, the final area in terms of the diagnosis of monoclonal gammopathies, I want to focus on light chain amyloidosis. This is a condition that's often overlooked and underdiagnosed. So if there is a clinical suspicion of light chain amyloidosis, whether it be somebody presenting with unexplained heart failure, peripheral neuropathy, again, GI side effects, or even some of the other typical clinical findings you find with macroglossia, step one is to screen for monoclonal process, and we already talked about that. And in amyloid, it's important for us to do a 24-hour urine in addition to the serum protein electrophoresis and free light chain assay. The second step is to demonstrate the tissue deposition of amyloid. And finally, we have to confirm that the amyloid is indeed coming from the light chain. Now, in order to demonstrate amyloid, if you do a fat and a bone marrow, fat aspirate and a bone marrow that for staining for amyloid, you identify these in 87% of these patients that you can demonstrate that there's amyloid. In the other 13% of patients, you will have to do an organ-directed biopsy in order to demonstrate that there is amyloid. Now, once you actually demonstrate that there is amyloid in the tissue, the next important thing is to demonstrate the protein of origin or identify the protein of origin. Previously, and even currently in many centers, we use immunohistochemistry and immunofluorescence. And in this particular setting, you can see that the amyloid deposits are staining for lambda alone. But this requires a pathologist who is very well trained in doing this. And more recently, we have been using a mass spectrometry based approach. We would do laser capture microdissection of the amyloid deposit, subject them to mass spectrometry, which then will allow us to identify the particular protein of origin. And this is important because you can have a variety of different proteins that can contribute to amyloid formation. So I think from a diagnostic standpoint, the important thing is the two steps. You have to demonstrate there is a monoclonal protein or a monoclonal plasma cell population. Second, you have to put them in the correct diagnostic category. It's a precursor condition or a condition that requires therapy. And if it's a condition that requires therapy, you have to put them into the specific category, whether it's myeloma, amyloid, POEMS, or any of the other conditions. Now, the next few minutes, I just want to quickly go through the disease response assessment. Obviously, one of the advantages with myeloma is we have a protein that we can measure in the blood in order to see if the treatments are working, unlike many of the solid tumors where imaging is integral. So typically, we want to have a minimum amount of this protein so that changes can be more accurately assessed. So typically, we want to have at least a gram of M spike in the serum or 200 milligrams in for a urine sample. If neither is present, a serum-free light chain difference between kappa and lambda of at least 10 milligrams per deciliter. If no serum markers available or urine markers, then a bone marrow with at least 30% plasma cells. Now, one of the things to keep in mind is quantitative immunoglobulins can be and probably should be used in certain settings. One of them is IgA. And as you can see here from a recent study where we did, the two correlates very well. One of the disadvantages of the monoclonal protein is because of the migration of the IgA to the beta region. Once it gets below a certain threshold, the M spike no longer actually is able to quantitate the monoclonal protein. As you can see in the blue line, by cycle 2, it seems like it's gotten down to 0. Whereas if you look at the red line, we know with the IgA, it is still present. And then subsequently with progression, you see the same thing happening. And so what do we need to follow? Again, I think the serum markers, the urine markers, and obviously the bone marrow aspirate in case of patients who don't have these markers, or even in the presence of these markers when you're suspecting a complete response. And also imaging studies as needed as per the current IMWG consensus criteria. So the response criteria, typically we use a partial response, a very good partial response, a near complete response, or stringent complete response. And more recently, we have been using minimal residual disease testing as well. So based on the serum and urine testing and the bone marrow testing, we can categorize these into different levels based on the depth of response. And how do we define progression? The progression is defined by a 25% increase from the lowest confirmed response in any of these values, whether it is serum M protein, urine M protein, or free light chain. But of course, they all need to also meet an absolute increase in the M spike of 0.5 gram or 200 milligrams in the urine, and similar cutoffs for the free light chain as well as bone marrow. There's also the concept of clinical progression, where someone might not meet the biochemical criteria, but still present with hypercalcemia, new soft tissue plasmacytomas, or increasing size of the bone lesions, all of which demonstrate disease progression, even though they may not meet the biochemical thresholds that are required. And more recently, we have obviously incorporated the Mrd negativity, knowing that getting to a deep response is important for these patients and obviously can make a difference in terms of their long-term outcome. We can use flow-based assessments, or we can use next-generation sequencing for detecting extremely low levels of monoclonal plasma cells in the bone marrow. And when you add imaging studies like PET scan, it increases the response assessment and the depth of response. So I think just to conclude, I think it's very important to make a distinction between the precursor stages and the active diseases. And advanced imaging can be quite critical, especially in the setting of myeloma. And obviously, precursor stages with end-organ damage should also be identified, like the MGRS neuropathy and the monoclonal immunoglobulin deposition diseases. And obviously, always keep in mind those conditions with small clones with significant end-organ damage, like POEMs and other rare plasma cell disorders like Schistler syndrome, etc. So with that, I will stop and take any questions before we move on to the next talk. Looks like we have some questions here in the chat box. So one of the questions is, how does the 24-hour urine protein electrophoresis helps in the addition to SPEP in routine clinical practice? I think there are two things. One is from a diagnostic perspective. Obviously, you don't want to miss a small monoclonal protein that could be detected in the 24-hour urine protein, somebody with amyloid or other monoclonal gammopathies of renal significance. And second, obviously, if that is the only measurable disease and often can happen in patients with light chain, predominantly light chain myeloma, then we want to use that for response assessment as well. The other question from Bala is, does antiprobe BNP need to be done in all cases of myeloma at diagnosis? It is something that we are increasingly starting to do, primarily because, like amyloidosis is a often overlooked condition. And it's simple blood test to be done. And if somebody has underlying cardiac amyloid in particular, we want to diagnose that early. So I think in patients with any monoclonal gammopathy, it stands to reason to do that test. Of course, it has to be taken in the context of the cost of the test and also the clinical presentation and everything else. So if you have even a slight bit of suspicion that there may be some underlying cardiac process, I think NT-proBNP can be quite sensitive, because if you have a negative or normal NT-proBNP, you can pretty much rule out cardiac amyloid. So the next question is, can amyloidosis present with only restrictive cardiomyopathy? It certainly can, and I think it is something to be kept in mind when you have cardiac restriction on echocardiogram or imaging studies, and you are not really finding any good reason for what's going on. So another question here, how to interpret M protein in SPEP, IFE, but normal serum-free light chain ratio with 9% monoclonal plasma cells in the bone marrow. Again, I think there's a small number of patients with myeloma with a clear monoclonal protein who will have a normal free light chain ratio, completely normal. And obviously, in somebody with this, you're probably talking about a monoclonal gammopathy of undetermined significance. And I think Dr. Rajkumar is going to go into a lot more detail. So maybe we can again come back to this at the end of his talk as well. Status of bone marrow transplant. Let's just hold off on the treatment discussion. Dr. O'Neill is going to be talking about some of the treatment approaches, and we can certainly come back to that. And then finally, we have one question about the frequency of monitoring for response. In the clinical trial setting, we often tend to do it on an every cycle basis, but in the non-clinical trial setting, I think we should at least do it in every cycle for the first 2 or 3 cycles until we are sure that the disease is responding. And after that, we can switch over to doing it less frequently once patients get to a plateau phase. Let's see, I don't see any other questions in the chat box. We are at the top of the hour here, and maybe for this interest of time, I will transition to the next talk. So it's my honor and privilege to introduce my colleague, Dr. Vincent Rajkumar, who needs no introduction. I know you all know him well. And he has done a lot of the seminal work in describing the precursor conditions in monoclonal gammopathies. And Vincent, thank you so much for joining this morning.
Thanks so much for having me, Shaji. Can you hear me well?
Yes, sir, we can hear you.
Perfect. So thanks so much for inviting me. And today I'll be covering MGUS, smoldering multiple myeloma, and MGRS. Let me share my screen. We'll start with MGUS, and I'll just go through the most important points that you have to keep in mind when you're talking about MGUS. MGUS is a term that was coined by Dr. Kyle. It stands for monoclonal gammopathy of undetermined significance. Dr. Kyle knew that MGUS is a precursor to multiple myeloma. But what he meant by undetermined significance was that when you first see a patient with MGUS, you don't know whether in the future they will get myeloma or not, whether they will get amyloid or not. Some of them may just stay MGUS for the rest of their lives. Some of them may progress. And when you first see them, you don't know that. And that's why he used the term MGUS rather than the previous term benign monoclonal gammopathy that was proposed. We usually detect a monoclonal gammopathy on serum protein electrophoresis and immunofixation. This is a normal serum protein electrophoresis and immunofixation. And clearly, when you have a monoclonal protein, it sticks out on the SPEP. And then on immunofixation, you can identify whether it's G, A, M, or in this case, IgG lambda. More recently at Mayo Clinic, we are using mass spectrometry to identify these monoclonal proteins, and it makes it actually quite easy to identify them. And you can see it is more sensitive than the immunofixation. So this patient was diagnosed with IgA kappa myeloma in 2007. When you go back 10 years, they had a monoclonal protein study done in 1997 and had immunofixation negative. But if you do mass spec on that sample from 10 years ago, you find you can identify the same monoclonal protein with the same molecular weight even 10 years ago, even though it was not picked up on immunofixation. So we are using this mass spectrometry. It also allows us to tell whether a small monoclonal protein is indeed a monoclonal protein or just daratumumab or elotuzumab and so on. Studies in Olmsted County show that a significant proportion of people in the general population have a monoclonal protein. Overall, in people over the age of 50, 3.2% had a monoclonal protein in the Olmsted study. You can see that the prevalence increases with age and is higher in men than in women. Dr. Kumar mentioned that we've also identified a term called light chain MGUS, and that's an extra 1% of the population. So, and if you use more sensitive techniques, we think about 5% of the general population now over the age of 50 has a monoclonal gammopathy. And this prevalence changes by race. We have studied African Americans and Blacks. And we find that in African Americans and in Black people, the prevalence of monoclonal gammopathy is higher than in whites, and that it also starts earlier in age. So by age 40 to 49, only 0.5% of whites have an MGUS, but 3.2% of Blacks have an MGUS. So keep that in mind. We haven't done similar prevalence studies in populations from India, and this is something that I hope some of you may be able to do it. You have to identify a geographically defined population and then do some really stratified random sampling type study. We hypothesize that just as in African Americans, the prevalence of MGUS is also likely higher in Indians, but that remains to be seen. It has also been shown that first-degree relatives have a higher prevalence of MGUS than the general population. So people who have one affected relative with myeloma or MGUS will have a higher risk. If you follow patients with MGUS over a very long period of time, you see that 1% per year go on to get myeloma or related malignancy. And you can further define this by the type of MGUS. If you look at the 2014 IMWG classification, one of the main changes in the diagnostic criteria would to classify MGUS into three types: non-IgM, IgM, and light chain. The type of progression is different. Non-IgM progresses to myeloma or plasmacytoma, IgM MGUS to Waldenstrom, and light chain MGUS mainly to light chain myeloma. All of them can progress to amyloid. the risk of progression is different based on the type of MGUS. This is the current understanding of the pathogenesis. Normal plasma cells undergo a first hit. This could be either trisomies or one of these 5 recurrent IGH translocations, either 11, 14, 4, 14, 6, 14, 14, 16, or 14, 20, and you establish the clone. So the clone in MGUS already has one of these 6 abnormalities. And then a second hit happens over the course of the next several years. And that second hit is still not clear. It could be RAS mutations, MYC abnormalities, 1q gain del 17. And whatever happens, then patients progress to myeloma at a rate of 1% per year. And then another further hits happen, which cause this myeloma to be refractory. Simple risk factors that can tell you about the progression of MGUS. Clearly, the most important one, the size of the M protein. The smaller the M protein, the less likely it is to progress. As the M spike goes up, the risk of progression goes up. IgM, slightly higher risk of progression than IgA. IgA, slightly higher risk of progression than IgG. Abnormal light chain ratio is seen in 1/3 of people with MGUS, and if you see it, that's associated with a higher risk of progression. You can put these 3 things together and have this risk stratification. It was first proposed almost 20 years ago, and it's very useful now in practice. Patients with MGUS who have none of the 3 risk factors, they have small M spikes, IgG, normal light chain ratio, risk of progression is very low. If all 3 are abnormal, the risk is higher. And if you look at it numerically, the risk of progression with no risk factors is only 2% over a lifetime if you look at other competing causes. So if you see a patient today, 20 years later, if they are alive and they come back and see you, they would have only a 2% risk of progression if they have a low risk MGUS. And low risk MGUS is almost half of all the MGUSs. So you can reassure your patients more effectively by risk stratification. This is the current algorithm that I recommend. This was published in Blood by Dr. Go and myself. It's a little bit more than what the IMWG recommends. The IMWG recommends that for suspected MGUS, if it's clearly uncomplicated and low risk, you don't need to do a bone marrow or skeletal survey. You can just follow them in 6 months, because the risk that you will find a high bone marrow plasma cells or bone lesions is very, very low. We also say in this article that if it's a small IgM MGUS, you can defer the marrow biopsy and the skeletal survey. And similarly, light chain MGUS, we are seeing more and more people ordering the light chain assay, more and more people having trivial abnormalities like a small increase in light chain ratio or a small increase in light chain level. Most of those are not really clinically relevant. So if the light chain ratio is less than 8, you can just treat it like a low risk MGUS and defer these studies. You will save a lot of patients the pain and cost of a bone marrow biopsy and skeletal survey by doing that. Of course, any worrisome feature that you think may be caused by the MGUS, you can proceed to this other algorithm. So all other patients, bone marrow biopsy is needed and skeletal survey is needed. Skeletal survey you can omit in people who have only an IgM monoclonal protein unless there's clinical question. Once you've made the diagnosis of MGUS, follow everyone in 6 months to make sure there's a change or not. If the patients are stable and there's no change and they're low risk, you don't need to do any more MGUS follow-up, because as I told you, the risk of progression is going to be very low. All you need to do is tell them that they have an MGUS, and if they ever have a symptom that's worrisome, they can get it checked at that point. Intermediate and high-risk MGUS need to be followed annually. Patients with probable progression in 6 months need to be worked up. Important to keep in mind the competing causes of death. When somebody is 70 years old and you look at 20 years later, the risk of progression is not 20%, because there are other reasons why they may die before the 20 years happens. And when we look at this large study that Dr. Kyle published in 2018 with 40 years of follow-up, you can see if you take 1,300 patients with MGUS very, very small number of non-IgMs actually progress to myeloma or related disorder, less than 10%. Less than 10% or only about 10% of IgM MGUS. The vast majority, 90% of patients with either IgM MGUS or non-IgM MGUS will die without progression or will not have progression over that period of time. So it's more important to follow these patients for their hypertension, prostate and breast and colon cancer than to keep worrying them about MGUS progression, which is quite low in reality. The next one is we'll talk about is smoldering multiple myeloma. This is a term coined by Dr. Kyle and Gripe in 1980. And that's because they found some patients who had more than 3 grams M spike or more than 10% plasma cells, therefore not fitting the diagnosis of MGUS, but still behave like MGUS in the sense that they did not have any lytic lesions or end organ damage. Subsequently, we have shown that these patients with smoldering myeloma, as defined by Dr. Kyle and Gripe, have a 10% per year risk of progression in the first 5 years compared to only 1% per year with MGUS. So they really need to be watched differently and followed differently. The IMWG updated the diagnostic criteria for myeloma because it was worried that we were missing patients with true myeloma and calling them smoldering myeloma by mistake. So, as Dr. Kumar pointed out, we added 3 biomarkers. If you have more than 60% plasma cells, you don't need CRAB or anything else. Just call them myeloma and treat them. More than 100 light chain ratio, particularly if the urine shows a significant monoclonal protein, is enough to call it as myeloma. More than 1 focal lesion on MRI. But by changing the myeloma criteria, we automatically changed the diagnostic criteria for smoldering. So smoldering is 10 to 60% plasma cells, not just more than 10%. Or more than 3 grams M spike or more than 500 milligrams of light chain in the urine, but no myeloma defining events. Keep in mind that the upgrade or the upstaging of new diagnostic criteria just eliminated a small number of patients with smoldering myeloma and called them myeloma. The vast majority of smoldering myeloma is still smoldering myeloma. And you can divide them into high risk and low risk. Low risk has a 5% risk of progression, high risk myeloma with a 25% per year risk of progression. What we want to do is to find out who these people are. The main paradigm change that you want to be aware of is that smoldering myeloma is not some intermediate smoldering condition between MGUS and myeloma, but rather it's a collection of patients for whom we don't know whether they have MGUS or myeloma. So if you take 100 patients with smoldering myeloma, some of them truly have MGUS, some of them already have myeloma, you don't know who's who. So when we say we want to treat high-risk smoldering myeloma, we are not treating a pre-malignancy. We are treating these patients who already have myeloma. They just haven't declared themselves when you first see them. If you give them a year or two, they will get myeloma, and that's why we want to treat them early. And that's the main paradigm change. It's not an in-between stage. It's a collection of patients, some of whom who have MGUS, some of whom have myeloma. And what we're trying to do is find who's who. That is why this curve looks the way it is. In the first 5 years of follow-up, all of the patients with true biologic malignancy declared themselves. 5 years later, the risk of progression slows to 3% per year because all of them left behind are mainly MGUSs. And at 10 years, the risk of progression of whatever you call smoldering myeloma is very similar to MGUS because all of the people who already have malignancy have declared themselves, and at 10 years, what you're left with is biologic pre-malignancy similar to MGUS with a 1% per year risk of progression. So what we want to find out is who are these people who progress in the first 2 years? And that's the high-risk smoldering myeloma. They can have a lot of these characteristics, including some cytogenetic abnormalities, a change in the M spike, high light chain ratio, and so on. Dr. Kumar and colleagues have made this very easy for us. All you need to do is look at the M spike, the bone marrow plasma cell percentage, and free light chain ratio. Any two of these three are high, M spike more than 2 or bone marrow plasma cell more than 20%, free light chain ratio more than 20. Any two of these are high. That's high risk smoldering myeloma. with a 50% risk of progression within 2 years. This has been validated by the IMWG. The IMWG did it in over 1,000 patients. Same thing. If you have any two of the three, you're in high risk. Of all patients with smoldering, 1/3 will have high risk, and they have a 50-50 risk of progression in 2 years. This is the group we want to consider early therapy. The Spanish randomized trial shows a significant delay in end organ damage. This is not myeloma progression-free survival of 25% M spike rise. This is true prevention of end organ damage. 90% reduction in risk of progression if you look at the high-risk smoldering myeloma by the 2220 with just lenalidomide and dexamethasone therapy compared to observation. And the Spanish group also sees a survival benefit, which has still persisted many years after this study was initially published. The ECOG study with lenalidomide alone, led by Dr. Loniel, found the same thing. You significantly delay end organ damage by using lenalidomide alone, and when you apply it to the high-risk smoldering myeloma patients, the risk reduction is 90%. So by using len or lendex, you prevent progression, 90% reduction in progression for patients with high-risk smoldering myeloma defined by the 2220 system. This is why when you see a new patient with potential new myeloma or smoldering myeloma, we treat as myeloma if they have end organ damage or myeloma defining events. If they have no myeloma defining events, I classify them to high risk or intermediate or low risk based on the 2220. If they have low risk, clearly observe or trials. If they have high risk, either you enroll them on a good clinical trial, or we recommend early therapy with len or lendex for 2 years. You may ask, why can I not just follow them closely? Well, that's what we did in the ECOG trial. And even in big centers following patients every month, they still miss the progression, because unless you're going to stay with the patient, the progression will happen in between the visit and you will miss it. And you can reduce a lytic lesion, renal failure, or some other progression by 90% by using one of these measures. And there is no adverse impact on overall survival. Len or lendex for 2 years is what we recommend. Now, we are trying to answer the other question people have, is why not treat them like myeloma? We would like to, but you want to prove that that's something that we need to do. So that's why the ECOG trial, SMM, is looking at dara-lendex versus lendex for all patients with high-risk smoldering myeloma. The trial is already accruing, 1/3 accrued. We're going to follow for overall survival and try and determine if patients with high-risk smoldering myeloma should be treated with just lendex or with myeloma-like therapy. We are doing more than these regulatory trials with CSER and ASCENT, which ask a more aggressive question, whether cure is possible if you intervene early. Dr. Kumar just completed the ASCENT trial. We'll see how the results play out. But this is something that we have to look at only in the context of clinical trials, where you do really aggressive therapy for high-risk smoldering myeloma with transplant and chemotherapy and so on. Now, the IMWG special risk stratification paper has some more pearls that you want to keep in mind. You just don't need to use only the 20-20 system. If you know the cytogenetics and the precise plasma cell percentage, FLC ratio, and bone marrow plasma cell percentage, you may find some people with very high risk approaching what is similar to myeloma. And if you wanted to treat some of these patients with myeloma-like therapy, that's okay. Similarly, if you're following patients and the M spike goes up by 0.5 gram and the hemoglobin follows by another 0.5 gram, and the bone marrow plasma cells is 20%, the risk of progression is very, very high. And so when you follow patients, if there is a change, a significant change in the M spike along with the significant drop in hemoglobin, you may want to consider myeloma-like therapy. Now, since smoldering myeloma is starting to get treated, the question is, we are only accidentally discovering smoldering myeloma patients, and is there a group of people we should be looking for smoldering myeloma already? And if you have time, you can read this article in Nature that was published. And what I argue here is, for the general population, we don't screen for MGUS or smoldering myeloma or myeloma. For high-risk patients, we don't screen them. We enroll them on studies. But for ultra high risk people, that is African Americans with one affected first degree relative, or say in India, if you have somebody with 2 first degree relatives with myeloma, it would be reasonable to screen their first degree relatives, not for MGUS, but to make sure that they don't have either myeloma or high risk smoldering multiple myeloma. I'll close with the MGRS, or monoclonal gammopathy of renal significance. First thing is to keep in mind that MGUS is a unique condition. In most malignancies, you have the polyp and you have the cancer. Whereas in plasma cell disorders, we have another problem, which is that the protein that is made by the plasma cell is not like a prostate-specific antigen or a CA125, some inert protein. This is an actual antibody, and that antibody can actually cause a problem. So we have polyp and the cancer, like everything else, but we also have the problems that we deal with because of the paraprotein. And that includes things like amyloid, cryo, neuropathies, fractures, etc. One such problem is kidney problems. And this was actually, before I go into that, keep in mind that 150 diseases have been associated with MGUS. And that's because MGUS is so common in the general population that if you check 5% of people with osteoarthritis will have an MGUS, 5% of people with a shoulder pain will have an MGUS. Every disease you can think of, 5% will have an MGUS. That doesn't mean the MGUS is causing it. We have to really look only at diseases where there's a clear proven association. And in this study that we did, we found that most of the associations described in the literature are coincidental, not really real associations. Dr. Sethi years ago found that if you take all patients with membranoproliferative GN, a condition that just a decade or two ago was thought to be idiopathic, we later on found that half of the MPGN, or membranoproliferative glomerulonephritis, was caused by hepatitis C. He found that of the remaining half, most of it was actually caused by monoclonal proteins. You can see here monoclonal gammopathy, positive for immunoglobulin, positive for kappa, negative for lambda. So he was able to show that a lot of MPGN is associated or caused directly by monoclonal protein. The term MGRS, or monoclonal gammopathy of renal significance, is simply a concept to remind people that you can have renal damage from the monoclonal protein without needing malignancy, without causing CAS nephropathy. CAS nephropathy is myeloma, but the kidney can be damaged by monoclonal proteins in many other ways besides CAS nephropathy. And to highlight that and to make sure people are aware of that, that's why this term was introduced. You can see under the umbrella of monoclonal gammopathy of renal significance, there are several distinct diseases, which includes amyloidosis, immunotactoid GN, cryoglobulinemia. This is what we call proliferative glomerulonephritis with monoclonal immunoglobulin deposits like MPGN, C3 glomerulonephropathy, thrombotic microangiopathy, crystal globulin glomerulonephritis, a whole variety of disorders. I can't go into all of this in detail, but I will tell you the main concept in the last slide that you really, really need to keep in mind. Just remember, MGRS is not a disease. It's not the name of a disease. It's the name of a book chapter. That means it's like anemia. There are many, many causes for anemia, and unless just saying anemia or MGRS doesn't mean you know how to diagnose it or treat it. It's a concept. You need to, if you find somebody with renal problem that has a particular presentation that's typical of something that a monoclonal gammopathy can do, then you need to work that up to find out exact pathologic entity that would require like a kidney biopsy. You don't need to biopsy a kidney in everybody who has a monoclonal protein, because if it's clear to you that this is due to some other cause like hypertension, diabetes, or some other renal problem, you don't need to do anything. But if you're worried that it's the M protein that's causing the kidney problem, then you have to do a biopsy to know exactly which of these many types that I talked about the patient actually has. you also need to be convinced that it's the MGUS that's causing that. There are other causes for amyloid. There are other causes for glomerulonephritis. There are other causes for C3 glomerulonephritis. So you need to be sure that it's the MGUS that's causing it. And then the management and the prognosis depend on exactly what precise renal disease you're dealing with. There is no treatment for MGRS. There's only treatment for immunoglobulin amyloidosis. There's treatment for membranoproliferative GN caused by monoclonal gammopathy. Then we can talk about treatment. But we can't have a general treatment strategy for MGRS because the treatment differs depending on the specific pathologic entity. Very similar to the treatment of anemia, depends on whether it's iron deficiency or B12. So I'll close with that. Happy to answer any questions.
Thank you, Vincent. I think there are a couple of questions here in the chat box. The first one is, in case of MGRS, when do you recommend transplant? If family not willing for transplant, how do you manage after 6 cycles of CyBody once the patient is in remission?
Again, as I mentioned to you, if somebody says MGRS, then I can't really help them. You need to tell me what exact MGRS did they have. Did they have an AL amyloidosis? Did they have a monoclonal gammopathy, proliferative glomerulonephritis with monoclonal immunoglobulin deposits? Is it light chain deposition disease? Then depending on the clinical circumstance and how severely the kidney is damaged, how likely the monoclonal gammopathy is going to come back, that's how the management will differ. So just make sure you know the precise pathologic entity. Only then you know, first of all, that it's the monoclonal protein that's causing it. So then we can decide whether or not it's worth going after the monoclonal protein, or will it be too dangerous to try to eradicate the M protein and you're better off leaving the kidney alone.
And Vincent, looks like this particular one was a light chain deposition disease.
Yeah, if it's light chain deposition disease, we try to see if the kidney is salvageable. If the patient has only proteinuria and nephrotic syndrome, then clearly myeloma-like therapy will save the kidney. If the patient already has end-stage renal disease, then you can just probably leave them alone because we don't know whether it will affect other organs or not, and just follow up. But we do want to try and eradicate the M protein. If the patient's not willing for transplant, then do other treatments like we do for myeloma, trying to reduce the monoclonal protein to as low level as possible.
Right. Here's one question. Which are do the free light chain levels increase in MGRS can be diagnosed based on monoclonality in bone marrow biopsy and normal FLC?
So again, it depends on the pathologic entity. You know, if somebody says that the renal biopsy has amyloid deposits and we did mass spec and it's light chains, then you don't need an abnormal light chain ratio. That's very unusual to have a normal light chain ratio, but you have the diagnosis made by the fact that you have the renal biopsy, which shows amyloid fibrils, and you've done a mass spec and it's due to light chains. Then you can go after the light chain and you have a diagnosis. So it really depends on the pathology, because how convinced you are that it's the monoclonal protein that's damaging the kidney is a clinical judgment call, and you really need to be convinced. So unless I know the precise pathologic entity, we can't tell. If somebody has thrombotic deposits in the kidney, my first suspicion is not it's a monoclonal protein. I really need to be convinced it's due to it. So the more normal the light chain ratio is, the more suspicious I am that what you're dealing with is a coincidental association or something was wrong on the biopsy.
So Vincent, one question. In a patient with hypergammaglobulinemia, for example, Sjogren syndrome, sometimes kappa is higher, the ratio is altered. Do you still consider it light chain MGUS because of the ratio?
Yeah, so this is very good question. This is important because in the old days, you know, we have to remember how was this light chain ratio defined. We just took a bunch of people at Mayo, the binding site studied Mayo patients, a lot of patients, young people were studied to establish the reference range of 0.26 to 1.65. But If you have a Sjogren syndrome and the immunoglobulins are elevated and the light chain ratio is slightly abnormal at 2 point something or 3, it's probably normal, and it's just that what we previously called 0.26 to 1.65 may be too rigid. So nowadays, even up to the ratio of 3 or 4, we don't really get too worried that it's a clonal process unless the clinical suspicion is there. So keep that in mind. Even if it is a light chain MGUS, as I told you in my algorithm, if it's less than 8, it's probably not going to be something you worry about. You can call it as a mild light chain MGUS or just an abnormality due to the reference range, depending on the exact ratio. Hope that helps.
It's one other question. 70-year-old with anemia, M spike of 0.22 gram per deciliter by SPEP, normal FLC ratio, bone marrow 9% clonal plasma cells, treat or not?
Yeah, it's the same as the crab features. One of the key point about the crab features is that you should believe that the crab features are attributable to the plasma cell disorder. If you say somebody has 9% plasma cells in the marrow and you're sure of that 9%, and the M spike is only 0.22, then you really have to arm twist me to say that this patient's anemia is caused by the plasma cell disorder. So I would be very skeptical of that. And I would really look very hard for all the other causes. I would not consider this myeloma and treat. I would just watch them closely. I would look very carefully at PET CT and other things to see if there is any possibility that there's something more that we are dealing with. Repeat the bone marrow in 6 months if you think that the M spike is going up. Anemia alone is something you can follow, and you're not going to be like ending up with renal failure or lytic lesions in this patient. So anytime in doubt, follow the patient. This doesn't sound very convincing for a myeloma for me.
Great. Let me see if we missed anything else here. Just a follow-up question: that light chain deposition disease, is it reversible or just prevents progression?
No, we have seen light chain deposition disease can be reversed. If the nephrotic syndrome it's very similar to amyloid. If you can stop the new light chains from being deposited, then you could reverse some of the nephrotic syndrome. If the patient's already on dialysis or end-stage renal disease, then the real question is, are we going to gain anything? But for most patients, that's 2 reasons why we do it: is prevent progression, but also to see if we can reverse it. I don't know, Shaji, what you think. You have done these transplants for patients. What proportion reverse?
Quite a few of them actually get the renal function improves, though it's not the same degree of reversal that we see with Cas nephropathy and those myeloma patients. Sometimes you do get quite a bit back to normal. These patients end up with some degree of persistent renal dysfunction often.
Do you think that there is any difference in how often we reverse the nephrotic syndrome with amyloid compared to light chain deposition disease, or both similarly you will see some reduction?
So the light chain deposition disease often has the renal function abnormality often tends to, the creatinine tends to remain elevated above normal, but the proteinuria do get better. But the amyloid, I think it's majority of the patients take up to a year for their nephrotic syndrome to start getting better. And a significant proportion end up with some degree of proteinuria, usually under 500 milligrams in the 24-hour urine, that stays on for long periods of time. And then there are these patients with amyloid where the proteinuria never reverses, in fact, continues to get worse despite light chains getting normal and no clone persists. And I think those are the patients where we probably kind of passed a threshold and we don't really understand that well. And same thing, I guess, is for the light chain deposition. Sometimes you get to significantly deranged renal function. You just can't salvage the kidneys anymore.
Sure. There's one more question that came, and that's very easy. If you're sure that the lytic lesions are from plasmacytoma or plasma cell proliferation, the bone marrow plasma cell percentage less than 10% doesn't make a difference. It's still myeloma. So if you look at the IMWG criteria, it's very clear how to handle these patients. They have myeloma, and there's about 3-4% of myeloma patients have a plasma cell percentage in the marrow less than 10%.
Excellent. I don't know, is Sagar, are you on?
Yep. I saw him.
Oh, you saw him? Okay. Well, let's see. Where is he? Okay. Sagar, can you turn your camera on? Maybe I'm not seeing.
I'm here. Give me
Oh, there you are.
You
have my name under your this thing. I kept wondering why I have two of me in there.
Yeah, give me 1 second though. Sorry. Do one more question, Vincent.
Okay. Sure. So one of the things that people ask, Shaji, is when to look for M protein. I think this is something that you as hem-onc people should really be educating internists on. It's so easy to do an SPEP free light chain assay and immunofix nowadays that if you start doing it like a SED rate, you're going to find a lot of these monoclonal proteins. So important to educate that we're not recommending this like a screening test. We're only recommending it if there is some clinical reason they're suspecting a monoclonal related process, myeloma, Waldenstrom's, or one of the other related processes. And otherwise, you're going to end up with a lot of these referrals, particularly mildly abnormal light chain ratios or immunofix only MGUS. If you follow my MGUS algorithm where, the small low risk MGUS, the small IgM MGUS, the small free light chain MGUS with ratio less than 8, that you don't really need to do much as long as there's nothing else clinically concerning, you will save yourself a lot of time and effort.
Thank you, Vincent, for that wonderful presentation. It's my honor and privilege to introduce to you Dr. Sagar Lonial, who probably needs no introduction to this group. He's the Chief Medical Officer at the Division of Hematology at the Winship Cancer Institute at Emory University. And Dr. Lonial is going to be talking about our current approach to newly diagnosed multiple myeloma. Take it away, Sagar.
All right, let me share my screen here. Oh, there we go. Now I should be able to. Okay, good. Can everybody see this okay?
I can see it. Well, go ahead.
Yes, sir.
Okay. And so I know I did share my slides earlier today with the meeting organizers, but that was the wrong set I set you. So that's what I was trying to fix when Vincent was doing that extra question. So thank you for the extra minute to sort this out. So I'm going to spend the next minute or the next 30 minutes or so talking a little bit about induction therapy in myeloma, which I think is another rapidly moving target. And, I think it's really based on several principles, one of which is make sure you've established the diagnosis. So it sounds like some of the discussion in the Q&A about, is this ready for treatment? Is this not? I think those are really salient points because one of the hardest things to do is to stop treatment in a patient that's already started on treatment. Because they are already going down this road where somebody has thought it's myeloma, and then you step back a little bit, put the whole pieces together, and it's not quite there. So I think taking the time to make sure in the beginning is really important. So there are some, in general, principles of induction therapy that I think are really important for us all to think about. And one of them is to induce a rapid and deep response, and to do so without significant toxicity. And so oftentimes we'll say we want to use our best drugs. And I don't think anybody disagrees with using our best drugs early on to try and get that deep response, but that really can't come at the price of a significant risk. And so risk-benefit ratio, when you're looking at second-generation agents, I think does become important, and I'll sort of give you my take on some of the subtleties there. I do think that the current standard of care is an IMiD plus a PI and dexamethasone, and I would argue that for many patients, the addition of an anti-CD38 antibody is probably a standard in at least a subset of patients, not unlimited therapy, but at least short duration therapy as part of initial induction therapy. So I'll start off showing you what I think is the current state of the art. And I guess what I mean by that is this is one of the largest series that has been reported with consecutive patients. So this is the RBD 1000 series from our center. Nisha Joseph and Ajay Nuka were the leaders of this analysis here. And this was 1,000 consecutively treated patients who all received RBD induction, single transplant, and then risk-adapted maintenance. And what we mean by risk-adapted maintenance is single agent lenalidomide for standard risk, and then RVD consolidation for 3 years for high-risk myeloma. And what I think you'll note is that the median progression-free survival for all patients in aggregate in panel A was about 65 months. So that's 5.5 years as the first PFS for patients on average. And if you, in fact, look down at standard risk versus high risk, what you'll notice is obviously a discrepancy. That part we've not been able to completely normalize for. But if you're a standard risk patient, your first remission is 78 months. And this data will be updated at ASCO in just a week. And actually the data looks even better with longer follow-up. What you'll also notice is that the median overall survival is 120 months. So 10 years is now the expected median overall survival for all patients in aggregate. And in fact, if you look at the standard risk versus the high risk, for the standard risk patients now, it's over 13 years is the median overall survival. And so I think there's going to be a lot of talk about what are the right endpoints in the context of induction therapy. I still am a believer that progression-free survival is the right endpoint. Similar to follicular lymphoma and CLL, where we know the outcomes can be quite good and can be quite durable. I don't think for a young, fit patient population that overall survival should any longer be the primary endpoint or even be a reason to discriminate between therapies unless the overall survival with a new intervention is worse. And so I think it's important to track OS, but I don't think OS should be you should do this versus something else. I think we're really looking at prolonging first progression-free survival or duration of first remission. Now, in the last decade, there have been a number of trials that have suggested that the replacement of bortezomib with carfilzomib would be superior. And this is really based on small single institution phase 2 studies, where clearly the NCR and stringent CR was really good. The 24-month PFS was really good from the group in Chicago. And again, if you look at all of these different things, the adverse events were slightly different in the KRD regimen, and we'll talk about that in a randomized trial in just a moment. But in general, what I think you'll notice is that from these small phase 2 studies, a hypothesis was generated that across the board, KRD should be better than VRD. And so Shaji actually did a really important trial, a phase 3 randomized trial that compared VRD at the top with KRD at the bottom. And this trial did not have transplant in it. So I think that is one important caveat. And when we talk about PFS, I think it's important, again, to look at differences in PFS between trials that don't have transplant versus trials that do have transplant. But more importantly, what you'll see here is that there were 2 randomizations between VRD and KRD, and then a second between continuous lenalidomide versus limited duration lenalidomide. And the second part, we don't know the answer to right yet, but we certainly do know the answer to the first randomization so far. And what you'll see here is that in over 1,000 patients that were randomized in this trial, that there was no difference in progression-free survival between KRD and VRD. Now, again, what are the caveats here? Well, the first is these were all standard risk patients. So I think what you can safely walk away with is a conclusion that in standard risk myeloma, there's no benefit for KRD over VRD. I think the other piece of information that came out of here is that the median progression-free survival is about 35 months in both arms. And that's almost half what I showed you on the RVD 1000 series. And so I think this really does continue to support the role of high-dose therapy if your goal is to maximize duration of first remission. Now, there are trials, I think, that do demonstrate some really important findings. And I'm going to spend a few moments on the Forte trial, which was a 3-arm randomized trial, 2 of which had transplant, 1 of which did not. And remember, what I showed you before, the data from Chicago, the data from the NCI at the US suggested that the depth of response with KRD was so good that perhaps you didn't need a transplant any longer. And so I think this trial really tells us a couple of things. The first thing it does is sort of a KRD with and without transplant. And the second thing that I personally believe, and we can debate this during Q&A if need be, is whether or not the replacement of an IMiD with cyclophosphamide really adds benefit. And so let's look at that data. So KCD transplant, KRD transplant, and then KRD no transplant. Those are really the 3 curves. And what I think you'll see here is in terms of progression-free survival, the group that got KRD and the transplant clearly had the longest progression-free survival. Now, this to me is a really important lesson, because if you looked at this data a year before they presented the final analysis, everybody was saying the response rates are similar. KRD with or without a transplant looked just like, looked the same. The depth of response was the same. The MRD negativity pre-transplant was similar between the two. Why would anybody ever need to do a transplant? And this to me hits a really important message, which is you still need to look at PFS. While those early endpoints are important and they may be useful in longer follow-up, making treatment decisions based on early depth of response right now, to me, is not quite ready for prime time. I think there's a lot more work for us to do to understand how best to utilize that early depth of response data as a predictor of long-term outcomes, recognizing that outcomes are likely not just a consequence of depth of response, but the type of treatment you use to get there or stay there. So I think of it as sort of a two-edged sword, not a single edge, where MRD is the only thing that really matters. Now, what you'll also notice is that KCD, the yellow curve here, is the worst curve of all of them. And so this to me really solidifies what I've said for a long time, which is that VCD should no longer be utilized in the context of induction therapy. And the same analogy I'd make here is KCD shouldn't either. And you're going to see in subsequent slides, the cyclophosphamide arm is always inferior in every situation we look at. Now, if you begin to break this down between who these patients are, what you'll see across the board is that the blue curve, which is the transplant curve, is always ahead. And in fact, in the highest risk group patients, the double hit patients, they actually had by far the best outcome with a transplant. So this idea that perhaps high risk patients may not gain benefit from transplant has not been borne out by randomized trial data. And in fact, the Europeans would argue that high-risk patients should get tandem auto transplant. I'm not sure I'm there. I certainly do believe that if you use risk-adapted maintenance, you can do just as well, if not better, with an IMiD PI in the maintenance and consolidation phase as a second transplant. Most of those European trials use lenalidomide as maintenance therapy in high risk, which I don't think really adds much benefit there. But again, I think these three curves clearly demonstrate the benefit of transplant in the context of standard or high-risk myeloma patients. Now, when you look at MRD negativity, I think one point that all of us on the call would agree upon is that really sustained MRD negativity is probably the most important endpoint. And if you go back a little bit, even to the old days in Arkansas, when Dr. Barloghi and his colleagues were looking at a sustained CR, it was the same argument. If you achieved a CR and lost it, your outcomes were worse. And I would argue the same with MRD. If you achieve MRD negativity and then lose it, it probably looks almost identical to the old non-sustained CR. And what you'll see here in terms of the high risk in yellow and the double hit in red is that the transplant arm had the highest rate of 1 year sustained MRD negativity, clearly better than KRD alone. And in fact, in the double hit, that was actually pretty bad. And KCD did actually the worst, probably of all of them. So again, another sort of nail, if you will, in the coffin of KCD or cyclophosphamide-based inductions in the context of newly diagnosed myeloma. Now, the second randomization that I think is really important speaks to the data that Jay Nuka from our group published almost a decade ago now on the VRD consolidation and maintenance. And what I really find quite impressive is that if you look at the high risk and the double hit, that's where the KR benefit really seems to be there. And so I think this is further support for the idea of risk-adapted maintenance. You could look at the standard risk curve here and say, well, look, they seem to have done pretty well with KR over R as well. And my argument for this is I really want to wait a little bit longer before I'm willing to expose standard risk patients to combined consolidation and maintenance when we know with lenalidomide alone, their median PFS is 78 months. And so unless you're going to ask a discontinuation question, meaning if they're in sustained MRD negativity with KR for 2 years, can you stop everything? I think you got to beat 78 months with KR, and the follow-up here is just too short to be able to answer that question. So for a standard risk patient, I'm not quite ready to go into doublet or triplet consolidation and maintenance yet, but certainly for the high risk, I think there's enough to lose in a high risk patient that I think it makes sense to make that decision based on current available data. Now, I'm going to show you another trial that I think is often interpreted incorrectly, and I'm going to show you my interpretation of this data. I'm sure that my colleagues on the call will have their own interpretations of this data as well. But really, this is the IFM 2009 study, which was published in the New England Journal a few years ago. And you may recall this was RVD with or without transplant. And then there was limited lenalidomide maintenance. It was really between 1 and 2 years was the average duration of lenalidomide maintenance. And this is the primary endpoint, which was duration of remission. Again, PFS clearly better in the RVD arm, or in the RVD transplant arm compared to RVD alone. But even more importantly, if you look at patients who were MRD negative, the PFS was better in the group that had the transplant than the group that did not. Now, this was with limited duration lenalidomide maintenance, and we're going to see data in just a week, actually a week from today, on what this looks like in the US version of this trial, where the lenalidomide maintenance was given continuously. But I think what we know is that the likelihood of achieving MRD negativity was higher in the transplant group, and the duration of PFS was longer, even if you achieved MRD negativity. So again, I think we've seen 2 trials now, and I would argue a third would be the RVD 1000 series, not a randomized trial, that all confirm the benefit of high-dose therapy and transplant in first remission, even in patients who generally are getting novel drugs or modern drugs as part of their initial induction therapy. So the question then becomes, is there a way to improve outcomes? And so given the movement of CD38 antibodies from refractory disease to relapse disease, it was only natural to bring it to induction therapy. And this was the first large randomized trial that attempted to do that. This was the European trial looking at DARA VTD transplant, DARA VTD versus VTD transplant and VTD consolidation. And where this trial, I think, is flawed is in the maintenance arm here, because they did DARA versus observation. So anything beyond this early looks at depth of response, I think, is an unfair analysis, because we don't do this anymore. We don't do observation in these patients. And so knowing how to interpret the second half of this trial is very different from how to interpret the first half. And so if you look at what we can glean from this, it tells you that it doesn't matter when you get DARA. You can get DARA as part of induction. You can get DARA in the maintenance phase. As long as you get DARA once in the early phase, you don't have to give it in both. And that's what I think is really important. This is almost like the rituximab story in lymphoma. If you get it as part of induction, you don't need it in maintenance. If you don't get it as part of induction, then you can use it in maintenance and sort of get back to where you were before. The worst group here was VTD with observation, so no DARA at all. And in fact, what you'll see is that the median PFS was about 30 months. That fits almost identically to the previous IFM study with no maintenance versus maintenance, and other trials that just do transplant with triplet induction and no maintenance at all. So this control arm is not a surprise. What I think is interesting is the idea that it doesn't matter when you get DARA, you don't have to always get DARA. And in fact, that concept has solidified the way our group approaches the use of daratumumab in newly diagnosed myeloma patients. And as I'll show you in the algorithm at the end, we give it as part of induction therapy, but we don't give it in consolidation or maintenance, because we think we've already gotten the benefit, and that allows us to use it in the salvage therapy setting if we need to. Now, you would argue, what's the best time to look at, or what are the best endpoints that support the use of an anti-CD38 early on? Well, I think clearly looking at depth of response. So this is MRD negativity here. You can see almost double in the group that got DARA post-induction, at least 50% better in the group post-consolidation. If you look at, again, 1 year and 2 years sustained MRD negativity, clearly better in the group that got DARA compared to the group that did not. And these, to me, are reasons to use it early on to really maximize that depth of response overall. And again, I think what is important is what you'll see is that if you got DARA VTD and you're MRD negative, you do better than if you got VTD and you were MRD negative. So this tells me that the choice of therapy and the duration of therapy are equally as important when you're talking about sustained MRD negativity. And that is, to me, an important concept, because oftentimes we get lost in the idea that just getting to MRD negativity is enough. How you do it and how you maintain it, I think, are equally important propositions across the board. Now, here you can look at the randomization in the second part here. And I think it's argued that DARA VTD followed by DARA gives you 48% sustained 1-year MRD negativity during maintenance and only 41% in the context of VTD with observation. But I would argue if you gave lenalidomide maintenance here, these numbers would likely be closer. And so I think this second randomization really threw off a lot of the way to interpret this data across the board. So I don't think we can get an answer from this. And there are lots of different ways you can look at this. But again, I think if you had len instead of observation, these differences would go away. I don't think they would hold up in the short term or in the long term. Now, what's closer to what we actually do in current practice, at least in the US? And that is the use of RVD with a transplant, lenalidomide maintenance therapy as continuous therapy. And that's what the Griffin trial did. The Griffin trial did RVD, transplant, RVD consolidation, len maintenance versus DARA RVD, transplant, DARA RVD consolidation, DARA len maintenance. And what they showed here again is that early on, the depth of response, CR rates, are almost double in the group that received daratumumab compared to the group that did not. And more importantly, if you look at MRD negativity, what you're seeing is doubling in the rates of MRD negativity at pretty much every phase of the process here. Now, this was only 10 to the minus 5. And we can debate this during the Q&A as well. I'm not crazy about 10 to the minus 5 as the endpoint. I'd like to use 10 to the minus 6 if I'm going to talk about discontinuation of therapy, if I'm going to talk about potentially curing patients, sustained MRD negativity. To me, 10 to the minus 5 is a good way to compare trials against each other and perhaps for regulatory endpoints. But even there, I'm looking at 10 to the minus 5 for at least 2 measurements 12 months apart in order to be able to say treatment X is better than treatment Y. What about looking through the DR maintenance period? This again suggests that there is benefit for DARA in the maintenance phase. I really want to see PFS before I'm going to make this switch. I'm not going to make this decision based on MRD negativity alone. But again, I think it's hard to argue with sustained both 6 and 12-month MRD, almost 3-fold higher in the group that got DARA compared to the group that did not. And while I think early on we said this is a small trial, we're not going to be able to see differences in PFS, at 3 years, we are beginning to see differences in PFS. And so your question to me might be, why is it taking 3 years? Well, it's taking 3 years because the control arm is so good. Our current standard of care is actually quite good. And so it's taking 3 years for these curves to really begin to separate. And just as a footnote, the RVD PFS curve here is almost identical to the RVD 1000 curve that I showed you at the very beginning. So again, these outcomes are really quite good. And to make it better, it's going to take longer to really see those differences. And then we'll get correlation between MRD negativity, sustained MRD negativity, and what it really means in the short term and the long term. Now, there are 2 CD38 antibodies. There's DARA and then there's isatuximab. This was data from the German group looking at ISA plus lenalidomide, bortezomib, and dexamethasone. So really the same design as I showed you in the Griffin trial, RVD versus ISA RVD here, only here they gave 6 cycles. So they gave more than 3 cycles as part of induction. And the primary endpoint was depth of response as part of the initial induction therapy. Their primary endpoint was MRD negativity at the end of induction. So at the end of 6 cycles of therapy, it was 50% versus 35%. Again, 10 to the minus 5 by flow cytometry was the methodology that they used. And again, a clear improvement across the board. Response rates non-MRD were actually not as different as one would have expected, but clearly MRD was the primary endpoint. And if you look at adverse events, not dissimilar from what we see with the addition of daratumumab. So we see a little bit more neutropenia when you combine an IMiD plus an anti-CD38 antibody. You do see some infusion reactions, but everything else was relatively expected. There's nothing here that jumped out as a unique adverse event that one would not have accepted across the board. Now, the last in the younger fit patients that I'm going to talk about, and then I'm going to do the older patients, was the master trial. And the master trial was really an interesting concept, and that is taking KRD plus DARA and looking at MRD over time, and then making decisions about treatment continuation based on MRD negativity at 10 to the minus 5, and sustained in their definition was 3-month intervals. And I will tell you, I think that's too short. I think sustained MRD negativity at an insensitive time point, like 10 to the minus 5, and at 3-month intervals is really not the best way to do this. But I think it was an interesting concept. And remember, these were younger, fitter patients. There were only 123 patients in this center. They used clonoSEQ as the method for MRD negativity, and the median follow-up is very short, less than 2 years. And I think that that's really important. So what you'll see here is the depth of response was clearly very impressive. 98% of patients achieved VGPR or better. And in fact, if you look at patients who achieved MRD negativity, it was really quite high. But the challenge here is that if you look at progression-free survival, very early on, some of these high-risk and ultra-high-risk patients were already starting to progress. And in fact, the difference between 1 high-risk abnormality and 0 in terms of PFS was similar, but this is only at 2 years. You're already starting to see people relapse at 2 years, because if they had 2 sustained MRD negativities at 3 months apart, their treatment was discontinued. That's not the right way to think about treatment discontinuation, particularly in the high-risk cohort, where you can see this was a mess. Patients were falling apart very early, even within the first year. And so the idea of being able to discontinue therapy, to me, was really, this was a flawed trial, I think, in this analysis. And the overall survival, again, with 24-month follow-up, I think it's not what I would have expected. Particularly in the high-risk group, where the OS should be far better than this. The PFS may be shorter, but the OS should be better. And I think that this is a victim of trying to stop therapy too soon with too insensitive an endpoint to really make that call. And here again is another way to look at it. You can see at 12 months, there are already patients that are starting to relapse, which you may see, but some of this may have been self-inflicted because they achieved MRD sure twice and then were stopped. So I think there are several lessons about this that I think we need to learn. It was a good, interesting hypothesis, but I think we need more work to really make it better. Now let's switch to the older, frailer patient population. RVD has been a standard based on the SWOG 777 study and the endurance trial that I showed you before. The group in Boston tried to modify this and make an RVD light regimen here. And what you'll see is that the median PFS is somewhere around 35 months. So again, not dissimilar than what we saw in endurance, not dissimilar from what we saw in the SWOG 777 study for older, frailer patients as well. But I think what really changed the game in terms of older, frailer patients was the MAIA study. And you all know MAIA, DARA-Lendex versus Lendex, randomized phase 3 trial, over 700 patients with primary endpoint being PFS. And what you'll see here is that PFS clearly is better in the DARA-Lendex arm compared to Lendex. Overall survival is actually better as well. And in this older, frailer patient population, what I said before of not using OS as a primary endpoint, I don't think applies. In the older, frailer patient population, you may not get a second chance to treat them. So I think OS is an important benchmark for those patients. But PFS clearly is the primary endpoint. And what we're seeing is almost 5 years PFS with DARA-Lendex, very easy to give, very well tolerated, and is associated with a lot of these deeper responses. These deeper responses translate into that better PFS over time. So with that, I'll stop and just show you our current algorithm in terms of how we approach things for the transplant eligible, which we don't use age. The oldest patient we've transplanted is 79. And so it's really about fitness more than it is age. For high risk, we have used KRD based on the Forte trial that I mentioned earlier. They all get early transplant, and then we give them risk-adapted maintenance with either now KRD consolidation and maintenance or just a PI, depending upon what their cytogenetics look like. For standard risk, we give them DARA-RVD as induction, early transplant, and then we don't use LEN, or we don't use the DARA in the maintenance phase. And then in the older, frailer patient, we used really the RVD modified regimen only in the high risk patient. In the standard risk patient, which is almost 80% of older, frailer patients, we do use RVD DARA as our primary go-to, and then again, use risk adapted maintenance here as well. So I think my conclusions yet are: do not use MRD to define duration of maintenance therapy yet. I don't think we're there. I think the addition of a second agent to LEN, whether it's an IMiD, whether it's a PI like carfilzomib, or whether it's an anti-CD38 like DARA, I think in the standard risk patient, the jury's out. I think I would wait longer to make that decision. But in the high risk patient, I think there's clear data that says if IMiD PI is better. And given that these can be very challenging patients to manage, I think we're doing that. We've done that for a long time. I know the group at Mayo has accepted that as well. I think many of us really think that doublets or triplets in maintenance for high risk should become a little bit more widely used. And with that, I'll stop and take questions.
Thank you, Sagar, for that wonderful talk. We have quite a few questions here, so maybe we can start off with this first one here. High-risk myeloma, how to consolidate and maintain. I think you kind of went over it. I don't know if you want to add on any specific aspects of that.
Yeah. So, the question about consolidation is an interesting one, because I think in most patients, we're not using consolidation. We're going straight at day 100 and adding in maintenance, particularly if it's lenalidomide. But I think in the high-risk patients where I'm really a little nervous, clearly if they've not achieved a CR, we're going to give 2 cycles of consolidation, likely with KRD. I think that's our current algorithm, is to use KRD in consolidation and then go to a less intense KRD maintenance. But the high-risk ones are where I'm more prone to use consolidation. In the standard risk, I almost never use it.
So, Sagar, maybe you talked about the dual maintenance. What if it was a young, fit, high-risk patient who had DARA VRD induction and a transplant? What would you do for maintenance? Would you still go back to a K and R maintenance, or would you continue with something else?
Yeah, that's a good question, and it's coming up more and more as we're starting patients on DARA RVD, and then we're getting their genetics back a month later, and it's abnormal, and they're doing really well, and so. I would switch to KRD, and the main reason is that while we were able to do VRD maintenance and consolidation for 3 years in a lot of patients, the neuropathy burden does start to add up. And so given that this is, even for high-risk patients, an 8 to 10 year overall survival, I would probably use KR there as a way to deliver a PI IMiD combination without inducing neuropathy over time.
And if I got it correctly, Sagar, you wouldn't use the DEX there at all. You would just start with the K and R.
No, I think actually we do use DEX, and we usually, Ajay can tell you exactly what we all do because he's got the data. But I think typically I keep the DEX on for the first year, taper off towards the end of the first year, and then try and get to KR for year 2 and year 3. And then at year 3, we stop the PI and just continue with lenalidomide alone.
Right. And I think the next question was about consolidation. I think you already answered this. This was about consolidation. Do you use that in daily practice or just clinical trials? I think you highlighted the use in the high-risk patient population.
Yeah.
And one other question here is, what's the advantage of transplant over just non-transplant? I guess transplant over RVD 9 to 12 cycles followed by LEN maintenance. I guess that's the IFM trial in a way, except that here the question maybe a little bit more nuanced. You're talking about 12 cycles versus 6 cycles of RVD.
Yeah, it's hard to give 12 cycles of RVD. I mean, if anybody can do it, it would be, many of us with experienced centers, and it's just tough. I mean, the data for, well, first of all, transplant is clearly cost effective. It clearly adds benefit and deepens response. Even if you have the same response rate early on, you're going to get more patients that are perhaps MRD at 10 to the minus 7 with a transplant than you are without a transplant. And to me, the PFS data is just so compelling. I think we'll see more data about that coming up soon. I think it's hard not to do it, because it's just so effective.
So one other question here, which is interesting, is if you're not using consolidation, would you consider starting maintenance earlier than day 100? Or is there a particular set of patients where you would do that, like high risk?
Yeah, so for the high risk patients, we typically start at day 60. So we do their restaging much earlier. And I would start the consolidation at day 60 for them, and then start the maintenance after the 2 cycles of consolidation. For the standard risk, they usually do fine, and giving them an extra month to sort of recover is not a bad thing. It gives them a little bit of amnesia about the transplant as well, which is not always a bad thing. And then starting at day 100, I think is fine. My approach to Len maintenance is I start at 10 and I stay at 10. I don't try and push the dose to 15. So I think waiting, to day 100 is fine.
And Ajay and Vincent, please chime in as well as you.
Yes, please do.
Please.
Ajay can correct me if I'm saying anything wrong.
You never say anything wrong. How's that?
If you said something wrong, it becomes right. Yeah, it's like, all right. Thank you so much. I don't have any other questions out here. So I think it's a great time to transition to the next speaker. And it's my great pleasure to introduce Dr. Ajay Nuka, who is Associate Professor in the Department of Hematology and Medical Oncology at the Emory University. Ajay is going to talk to us about the approach to treatment of relapsed multiple myeloma. Thanks, Ajay.
Thank you for having me. Shaji, one of the big things that I always dread about is following a speaker like Vincent or following a speaker like Sagar, who leave you with such high note, and everybody has the expectation for me to speak the same way. And here you see today, it's a succession of the good speakers of Shaji, Vincent, and Sagar. I'll try to make the best, but please bear with me. So here are my disclosures. I'll start with the clinical vignette, purely to give you a perspective of how complex this decision-making goes on, especially when you're in the early relapse setting with too many options, and which is the right option to choose is almost always the most difficult task. So this is a 69-year-old female with standard risk myeloma, received an induction regimen with RVD, went for an upfront transplant, achieved a CR. So unlike most people who would go on to maintenance, 80 to 85% of our patients in our institution go on to maintenance with risk-adapted maintenance. And this is one of those 15% of the patients that did not choose to go for a maintenance. So 4 years after the transplant, she started showing evidence of biochemical progression. And there is more, now she's becoming anemic. Now, what is a second-line regimen that would be in the best interest of the patient, aimed at prolonging the survival? So all of these are optimal treatment choices. You look at the KRD, ERD, daratumumab plus Revdex, and IRD. So the complexity of choosing the right regimen here would be the next theme of the talk. What I'll try to do is to prepare the framework of what are the available agents out there. Number two, what are the general principles that guide us towards choosing one over the other, and making a nice segue to for all the newer agents that Shaji would be talking about as the next talk. So this is one of the initial slides that I always show. I'm fully aware that I'm not talking about the induction treatment. And the reason why I show this is to show where is the place where we can get the best bang for the buck with the available agents. So the first part is what Dr. Colonial just talked about. In a transplant eligible patient or an ineligible patient, this one option that needs to be emphasized more and more, where you prolong the PFS1 benefit, it adds up to the overall survival. So where I'm focusing today is to manage these relapse, where we have all these newer agents that were tested in this space. If these are found to be really effective, they move on to earlier lines of treatment. So this is our data from Emory among the patients that got treated with RVD triplet regimen in 1,000 patients over a 10-year period. And we had the opportunity to follow them over a longer period of time, where the median PFS in the standard risk patients is shown to be close to 77 months, and the high risk patients are 42 months. And if you look at how it translates into the overall survival, the median overall survival for a standard risk patient is reaching 13 years. So for the high risk patient, these are numbers that we have not seen before with risk adapted maintenance, seeing those 7-8 years of overall survival again, this is data from 10 years ago, and all these patients that are receiving the active treatment, these show to the advances that were made in these treatments. So now if you look at the comparison between the PFS and the overall survival, the PFS1 benefit, what I showed you, where we need to put more emphasis, is probably half of a myeloma patient's journey. So, which clearly talks about how to improvise on those regimens in the upfront setting, and I'll be focusing more in the later half of the myeloma patient's journey. So let's talk about the scope of the problem. So in 2022, we have 35,000 cases that will be diagnosed, 12,000 deaths. And when I look at the SEER stat this morning, so they're estimating 160,000 people living with myeloma. Again, this is based on a 5-year survival rate of 57%, a median overall survival of close to 6 years, and which is very different than what you saw in the previous slide. So if you look at the prevalence as the resultant of the incidence times duration, if your incidence is not changing much or only increasing, and the duration, this is the time where the patients are living, the myeloma pool is increasing. This is grossly an understatement of what we are seeing today. So we're expecting close to 30,000 people or 300,000 people with myeloma to be living in the United States. So now, how have we improvised on the overall survival, similar to what we talked about the PFS1 benefit? Now, Shaji had shown years ago, I didn't know if there was a follow-up for this. My apologies for putting in the last one that I could find from 2012. The disease remission duration changes with each line of therapy. So the remission duration decreases with each line of therapy. This holds good even in this current day of all these modern therapies. So what I want to focus is, so the right regimen, the regimen that we choose for the myeloma patient, given at 2 different points, can result in 2 different outcomes for the same regimen. So which brings us back to the point that choosing that right regimen for the early relapse is extremely essential so that we gain the best benefit for that regimen. So now in 2022, what are the approved regimens that we have? The immunomodulatory agents, thalidomide, lenalidomide, and pomalidomide. The PIs, bortezomib, carfilzomib, ixazomib. Naked antibodies, the CD38 antibodies, daratumumab and isatuximab. Anti-Islam of 7 antibody, elotuzumab, we have a selinexor and exportin-1 inhibitor, belantamab, an antibody drug conjugate targeting BCMA, and the CAR-Ts, the ide-cel and cel-to-cel, which are the recent approvals, which Shaji will be talking as in the next section. So we also use the chemotherapeutic agents in some part during the refractory setting as a part of the combination regimens. So how do the immunomodulatory agents work? So the image, back 20 years ago, when we started using this for the first time, we did not know even what is the real mechanism of action is. It's only within the last 10 years we were able to see that the image bind to cereblon and act in the degradation of the transcription factors, the ICROs and the ALOs, and have a direct tumoricidal effects as well as the T cell activation proliferation leading to the anti-myeloma effect. So now we have a new compound, which is iberdomide or CC220, and there is another one, CC92480, which bind to the cereblon more efficiently, highly efficiently, and the degradation at much minimal concentrations, showing that these are much more potent cell mods or cell mods, the new name for the cereblon E3 ligase modulation. So they also induce IL-2 secretion as well as the myeloma cell kill much more efficiently than those 2 agents. So this is how I would summarize. Thalidomide, a less potent and a higher toxic drug. As we go on, we see the more potent drugs with lenalidomide, pomalidomide, and iberdomide with a higher potency. And the toxicity is much similar to what you see with the pomalidomide and lenalidomide. So moving on to the proteasome inhibitors. So proteasome, which is a hollow core, which is the 20S hollow core, has a regulatory cap, which is the 19S. And the tag the proteins that are ready for degradation get bound to the 19S, and they're spit out in the hollow core as amino acids. These have separate the target sites for the carfilzomib as well as bortezomib are highly different, and which explains for the off-target side effects that you see with these and the specific side effects that you see with these two different proteasome inhibitors. So we did have other antibody therapy combinations, many more approvals within the last 3 years. I talk about these antibodies, the CD38 antibodies, that by the on-tumor effects with the complement-dependent cytotoxicity, the antibody-dependent cellular cytotoxicity, as well as antibody-dependent cellular phagocytosis, as well as inhibition of the ectozyme activity. The daratumumab, isatuximab fall into this category, leading to the myeloma cell death. So inotuzumab is the other antibody that we just alluded to. It has dual mechanism of action, a direct apoptosis, as well as tagging for the recognition of the antibody-dependent cellular cytotoxicity. We quickly move on to talking about selinexor. This is an exportin 1 inhibitor. Exportin is a transporter protein that takes the cargo proteins outside of the nucleus, which includes the tumor suppressor proteins as well. By blocking this, you're retaining the glucocorticoids as well as the tumor suppressor proteins, aiming at the tumor cell death. So belamaf is a antibody drug conjugate targeting ADC. It has a multimodal mechanism of action, both the ADCC as well as ADCP. Not only that, it delivers MMAF, a maytansine conjugate, directly to the cell, directly to the myeloma cell, causing the cell death. So those are the available classes of agents. Now I'll talk about the general principles of how to use these available agents and talk about the data that supports the usage of these. So when you talk about the IMWG consensus criteria for response in multiple myeloma, so the biochemical progression and clinical relapse are quite different. When the disease is coming back, the harbinger for a relapse is typically a M protein to be discovered in the blood or in the urine. And these the numbers of the semantics are clearly meant to understand what qualifies for a progression. But in reality, every progression should not be a knee-jerk reaction for anybody to start talking about treatments. So progression based on the M protein parameter increase only can be watched as a biochemical progression, but things that needed to be watched out for are, what is the pace of progression? How did the patient initially present with? Does the patient have a high-risk disease? All these matter into the decision-making of whether to initiate the treatment or not, which is very different than the clinical relapse, where the CRAB criteria appear as a resultant of the progression, which calls in for initiation of the treatment at the earliest possible. So the general treatment principles for the early relapse, we want to see what is the salvage regimen that we'll be using down the line, and sticking with the preferred regimens and not to cannibalize the future treatments. The choice of the regimen should be allowing for us to use the best, most optimal approach based on the prior treatments, and that will allow for us to still continue the treatments down the line. And that is the most optimal regimen. So what is the earlier lines of prior treatments that the patient received? How many earlier lines of therapy did the patient receive? Is the patient refractory to a specific treatment? If you look at the potency of these proteasome inhibitors and the potency of the immunomodulatory agent, patients who may receive pomalidomide may not be, lenalidomide may not be an amenable down the line treatment option for them. Similarly, carfilzomib, patients who receive carfilzomib, which is a much more potent PI, bortezomib may not be used down the line. All these things need to be taken into consideration as well. So again, going back to the disease progression on the standard dosing, could we increase the dose, add the third agent? These are all potential questions that needed to be addressed at the time of making the decision. The other factors that needed to be considered are the patient preference. Is it amenable for this patient to receive the treatments? And could a patient coming from 4 hours away, would having a twice weekly regimen like carfilzomib, would it be an optimal strategy for this patient? The answer is no. Potentially trying for an oral regimen in those patients would help a situation like this. So first, from a treatment algorithm perspective, reviewing the resistance patterns, what the patient has received as a prior therapies, and whether the patient has a biochemical relapse versus the clinical relapse. Should the patient be watched, or should the patient be asked to start the treatment right away? And understanding what the disease status is in terms of the standard risk versus the high risk disease will allow us to make that right decision. And more importantly, it is not a one size fits all, and the dose modifications need to be made based on the comorbidities as well as the tolerability based on the prior history as well. So here is a summary of what was put in by Shaji and Vincent for how to approach patients who at first relapse who are not refractory to lenalidomide or refractory to lenalidomide. This is more applicable in the US, where patients continue the maintenance until progression, especially with len or a combination maintenance strategy. And what are the options that are available for these patients at the time of the first relapse who are refractory to len or not refractory to len? And again, for the second relapse or higher, there are several additional options. I'll try to summarize most of these within the next 10 minutes. And I'm happy to answer any specific questions for any of these clinical trial data. So what we put in the previous slide, it is a much more elaborated perspective of what is so now that we are using the antibody combinations much earlier in the treatment, should the antibodies be continued until progression, which we don't do at our institution, as Dr. Loniel alluded to before. And if patients are progressing on an antibody-based regimen based on the clinical trials, what are the options that we needed to use? And this clearly provides a guideline or a framework to understand what are the existing options out there. And again, the patient-related factors need to be taken into consideration before choosing which regimen over the other. So for the first question that I asked, so the 69-year-old female who went for a transplant who has a biochemical progression. So the ASPIRE trial compared KRD versus RD. And if you look at the doublets of RD as the controls across, these doublets did relatively the same, offered the same PFS across the board. So 14.7 months in the Tourmaline MM1 trial, 17.5 months in the Pollux trial. Eloquent trial had 14.9 months and 16.6 months in the ASPIRE trial. The addition of the third agent has resulted across the board in improving the PFS benefit. And if you look at the hazard ratios, these are all equivalent, more favoring the daratumumab-based regimens at 0.44, which is a 56% reduction in the risk of progression. So now, with the earlier use of the monoclonal antibodies, what are the options at the time of relapse? So these are the patients who are using the len until progression. What are the choices that we have? So here are three of the trials I've summarized: the DARA plus VD and the CASTOR trial, and Optimism combining pomalidomide, bortezomib, dexamethasone, and the IKEMA trial using ESA and carfilzomib and dexamethasone. The isatuximab is the other CD38 monoclonal antibody. So across the board, you're seeing the overall response rates of close to 83%, 86%, and 87% with these regimens, highly effective regimens, as you can see, and the median progression-free survival is much, much higher than any of the previously talked about RD-based treatments. So Eloquent 3 trial, it randomized elotuzumab Pomdex versus Pomdex for the primary endpoint of relapse for the primary endpoint of PFS. And here, the 3-drug regimen of elotuzumab and pomalidomide did considerably better with a hazard ratio of 0.54, and the median PFS was 10.3 months compared to the Pomdex PFS of 4.7 months. This Pomdex across the board, you see at 4 months to 6 months as the comparator arm. So Apollo trial, which is similar to, which is comparing daratumumab pomalidomide plus dexamethasone versus pomalidomide dexamethasone for the primary endpoint of PFS among the len refractory patients, had a similar benefit. As you can see, the dara Pomdex had a PFS of 12.4 months versus Pomdex had a PFS of 6.9 months. So ICARIA trial, which is a which is using isatuximab instead of daratumumab, similar to the Apollo trial for the same endpoint of PFS, had a PFS benefit of 11.5 months versus 6.4 months for the Pomdex arm. So all these trials with the pomalidomide backbone showed the benefit of the addition of a third agent. Now, how about the carfilzomib dexamethasone backbone? There are two trials that evaluated carfilzomib dexamethasone backbone versus the addition of an antibody with daratumumab. Candor trial had KDD versus KD for the primary endpoint of PFS. And here, as you can see, the median progression-free survival for KD, as anticipated, is close to 15.8 months. And with KD significantly showing the separation of the curves. And at the time of the median follow-up, the PFS has not been reached here. So as you can see, patients at 24 months, 60% of the patients are still responding to the treatment. So moving along to the Boston trial using selinexor in combination with bortezomib dexamethasone versus bortezomib dexamethasone in the early relapse setting for the primary endpoint of overall response rates and the secondary endpoints of overall survival. Again, this is an early trial. So going back to talking about selinexor as an exportin 1 inhibitor, there are a lot of off-target side effects. These need to be dealt with in a very diligent fashion. Patients need to be monitored very, very closely at the approved dosing of 160 milligram, at the approved dosing of 160 milligram weekly cumulative dose per FDA, given 80 milligram 2 times in a week. It is almost not tolerable among patients with refractory multiple myeloma. So if you reduce the dose and add with a PI, so this becomes a lot more tolerable. And I usually go at 80 milligram per week with this combination, and it can result in significant benefit. So in this specific trial, bortezomib dexamethasone had a PFS of 9.4 months, and selinexor in combination with bortezomib dexamethasone had a PFS of close to 14 months, leading to the approval of this specific regimen. So shifting gears to the antibody drug conjugates, the belamaf, which we talked about, had an overall response rate of 31%, leading to the approval in data refractory patients who had seen 4 lines of prior treatments. These patients would have an overall response rate of 31%, and the approved dosing was 2.4 milligram per kilogram. What is more interesting is the duration of response. So only 1 in 3 people respond, but when they respond, the duration of response is close to a year. So a good option for patients who who do not have a CAR-T slot, who are not a clinical trial candidate, and who are in need of an urgent treatment. And you will see those responses very earlier on. If the patient is not responding, you'll see it by the first month. If the patient is responding, the 1 in 3 patients will have a response all the way up to the 12-month mark. So the biggest challenge for delivering this drug in the safer way is the corneal toxicity. I'll put it this way. I've never seen anybody that lost the vision because of the drug, but the corneal toxicity is real, probably related to the MMAF, the payload. And among these patients, among these 95 patients, 72% had some grade of keratopathy. The visual changes happened in 18%. And there are the symptoms that are seen in close to 56% of the patients. If you look closely in the inner circle, only 3% of the patients discontinued the drug in the trial due to any adverse events related to the corneal toxicities. So DREAM5 platform is a very interesting platform, as you can see. The idea here is to improvise on the delivery of the belantamab, utilize its immunogenic cell death, and how to lower the dose of belantamab to lower the corneal toxicity, at the same time use the synergy to gain the anti-myeloma effect. So there are several partners here, as you can see, the OX40 agonists, the ICOS agonists, GSI inhibitors. These are all, most of these have finished accrual. There's a good presentation at ASCO talking about the nirogacestat, a GSI inhibitor. The first patient that we put on this trial at 0.95 milligram per kilogram of belantamab in this combination with niro. The patient is still in remission after 2 years. So the responses are real. And you can see those responses augment with these combination treatments utilizing the synergy. So I know I went through very quickly, but I'm happy to take any questions. And
Ajay, that was a really comprehensive overview. So we have a few questions in here. One of them pertains to the role of a second autologous stem cell transplant in relapsed myeloma. What are the situations we would visit?
Thanks, Shaji. That's a great question. So the more benefit that we see with all these transplants, leading to almost 8 years, 9 years of these PFS1 benefits. I think data came from your institution showing that if you have the PFS1 benefit from the first transplant, and if you don't find any other regimen that is reaching as close to that benefit that you're expecting from the second transplant, those are all the patients that should be considered for a second transplant. For all the reasons that we talked about, it is extremely cost-effective compared to any of the other regimens. And I'm a big fan of that.
Ajay, would you do FISH in all the patients at time of relapse? And if so, are there specific probes you would limit your use to, or any other specific genomic testing you might do at relapse?
This is another great question. So we have always been proponents of using FISH at the time of relapse. All the high-risk features are the ones that any acquired cytogenetic features that you expect at the relapse are the FISH probes that we use, especially deletion 17p and so on. So for all the right reasons that we alluded to before, can we wait on these patients, or should these patients be treated as aggressively as possible? So it is helping us with the treatment decision making. So we also include the translocation 1114 in all the patients at the time of a relapse, not for any other reason. Some of these patients have become, they come to our institution with their initial testing that was done somewhere outside, and we may not have the right probes that were tested at the time of the diagnosis. So if the patient did not have translocation 1114 done before, I definitely would encourage to use that for the topic that you'd be going to cover.
Wonderful. Possible mechanisms for daratumumab resistance?
Great question. So we thought initially it could all be from the CD38 stripping, but in reality, it's not the case. It is still under review. We still don't understand what exactly goes on, why people become resistant to this CD38 monoclonal antibodies. But one thing that we had shown before was patients who are refractory can be retreated with daratumumab after a certain amount of time off treatment.
Perfect. One last question here before we move on. Somebody with, let's say, non-transplant eligible patients who got VRD induction followed by LEN maintenance, what would be your regimen of choice for the first relapse?
So definitely a combination of daratumumab. So if the patient is data naive, probably that would be my first regimen. The combination, the partner would be either pomalidomide or carfilzomib. So if this is a patient who's elderly and who I'm afraid may not be able to tolerate carfilzomib, probably the data supports from the Apollo to use combination of pomalidomide. If the patient is a good candidate for carfilzomib, that would be my choice.
That's great. I think in the interest of time, we will move on. Thank you so much, Ajay, for that wonderful presentation. And I'll spend the last few minutes here picking up from where Ajay left off and talk about some of those emerging therapies that are coming up. So let me go ahead and share my screen. All right. So we already talked about the entire treatment paradigm in this disease. Obviously, you heard from Dr. Loniel what we're going to be doing in that first set of therapy, which is very important, the treatment of newly diagnosed myeloma. We heard from Dr. Noka how to manage those initial relapses, the overall approach to when to treat, how to use combinations, and how to use the data from the phase 3 trials, particularly with the 3 drug combinations. Now, unfortunately, with myelomas, we all know very well the disease continues to relapse after all these therapies as they become resistant to these treatments, and we are invariably faced with the conundrum of treating disease that has become refractory to these multiple drug classes. In fact, when you look at the outcomes of patients who have become refractory to the three classes, the IMiDs, the proteasome inhibitors, and the monoclonal antibodies, the median PFS or median overall survival for these patients is again just over a year. And in fact, when you look at the patients with high-risk cytogenetics, they are more likely to become triple class refractory much earlier than the others with standard risk disease, and offers and is a very significant challenge for our patient management. So what are the options when patients become, obviously we already heard about selinexor, we heard about belantamab, both of which are currently approved. The CAR-T, we'll talk about it in a little bit, it's again approved. There are 2 CAR-Ts that are approved. There are 2 drug classes, the panobinostat, which is an HDAC inhibitor. There were phase 3 trials demonstrating benefit, but since has been withdrawn from the market by FDA for lack of follow-up studies. There's melflufen, which is a different type of alkylator, which is kind of up in the limbo, having been withdrawn again from the market. But there are, what is really exciting are the whole host of new therapies that are coming through clinical trials, particularly the T-cell redirection therapies, the new set of immunomodulators, though the cell modes, and targeted therapy like venetoclax, which is a BCL2 inhibitor. So out of this, obviously, the immunotherapy is one of the most exciting in myeloma. Obviously, we heard a lot about the monoclonal antibodies from Dr. Nuka, but I think what has really taken the field by a storm is the introduction of the new T-cell redirecting therapies. And obviously, when you look at this timeline, you realize that it's been 5-6 decades that people have been working on trying to re-engineer or manipulate the immune system to try and get rid of the tumor cells. Obviously, some of the breakthroughs came up in the early 2000s when the initial chimeric antigen receptor T cells were applied for the treatment of acute leukemia. And eventually, from a myeloma standpoint, now we have 2 that have been approved. So when you think about the overall T-cell redirection strategies, obviously we went from something that is quite non-specific to something very specific. Obviously, post-allogeneic stem cell transplant, DLI, or donor lymphocyte infusion is something that's familiar to many of you. It is, again, an adoptive T-cell therapy approaches. There's clearly lymphokine-activated killer cell approaches that have been used indirectly by IL-2 therapies. There are ongoing studies looking at tumor-infiltrating lymphocytes, an area that has been explored for a long time, and hopefully we will see some of these actually being approved for solid tumors later this year. But one, I think, concept that really made the immunotherapy a lot more feasible was the introduction of the chimeric antigen receptor therapy, where you basically take a modified T-cell receptor that is then transduced into autologous T cells and re-infuse back. So when you think about the structure of the chimeric antigen receptor T cells, again, these T cell receptors obviously have a binding domain which can bind in a variety of different technologies have been utilized in order to allow the T cell receptors to bind to a variety of different ligands or antigens, including nanobodies, cytokines, single chain fragment, as well as other ligands. There's a hinge region, there's a transmembrane domain, these are fairly standard. And then what is again changing is the intracellular portion. Obviously, there's a co-stimulatory domain, which a variety of them has been used. The majority of them in myeloma has been using 4-1BB. There's the activating domain, which is a CD3. And then even beyond that, there has been some newer approaches to try and make these T cells more effective, either by having them secrete cytokines side by side, or using other different approaches. So the first CAR T cell that was approved for use in myeloma was the idacaptogene viculacil or ida-cel. This is a BCMA targeting CAR T. BCMA or B-cell maturation antigen is universally present on the myeloma cells. Again, this one uses a 4-1BB stimulatory domain as well as the CD3 epsilon. You have the again, you have the autologous CAR T cells, which are transduced via a lentiviral vector that encodes for this particular CAR T construct. Now, most of the data that led to the approval of ide-cel came from the pivotal KarMMa study, where, again, when you look at all these CAR T trials, very similar approaches. You can see that you have a leukapheresis for collecting the T cells. There is bridging, sometimes to control the disease until the CAR T cells are manufactured, which can take 4 to 6 weeks. Then there's lymphodepletion, typically with fludarabine and cyclophosphamide, which is then followed by the CAR T infusion. Now, with this approach, again, the KarMMa trial, the initial phase 1 study with the phase 2 expansion, you can see that there's some dose-dependent increase in the response rate. But when you look again at the overall patient population who received at least 300 million CD30 CAR T cells per kilogram, you can see that these patients actually had an overall response rate of almost 73%, including a complete response rate of almost 33%. And this has to be taken in the context of these patients with a median of 6 prior lines of therapy, almost 70 to 80% of them being triple class refractory. And these are the patients who are in those retrospective studies had a median PFS that was in 4 months and overall survival that was like 9 to 12 months. So obviously, it's hard to compare that with other cohorts. It's a single arm study. Phase 3 trials with the ide-cel are ongoing. You can see that the median PFS is about 8.8 months. The median overall survival is close to 2 years. So certainly for that particular patient population, this is obviously of great interest. The broader applicability in the earlier lines of therapy will have to be explored once we have results from the ongoing phase 3 trials. Now, there are 2 side effects that I think we need to be really aware of in the context of CAR T. One of them is the cytokine release syndrome. That's very, very common. Almost 84% of the patients will have at least one CRS event. The majority of them are thankfully grade 1 or 2, but we do see up to 10 to 20% of grade 3 or higher CRS depending upon the particular CAR T construct that we are looking at. They generally tend to be pretty early in onset, usually about 1 day, and usually last for less than a week. And patients, almost half of the patients, at least in those initial studies, ended up getting tocilizumab, which is an anti-IL-6 antibody, to try and control CRS, and corticosteroids in a smaller group of patients. But again, I think as we have become more familiar and more comfortable managing cytokine release syndrome, we are starting to use the tocilizumab much earlier and more frequently, with the understanding, again, gleaned from the ongoing studies, that the tocilizumab does not affect the tumor response outcome. Now, the other CAR T cell that is recently approved is cilta-cel. And this is, again, was a phase 1b/2 study. Heavily pretreated patients get the T cell collection. They receive bridging therapy if needed, lymphodepletion with cytoxin and fludarabine, followed by the cilta-cel infusion. And again, in a group of almost the initial set of patients, you can see that almost 100 patients who are all heavily pretreated, triple class refractory patients for majority, almost 98% of these patients actually responded, which is really remarkable given what we have seen in this group of people with other approaches. And in fact, 82.5% of these patients were able to get to a stringent complete response. These responses tend to be fairly rapid, and these responses also appear to be fairly durable. In fact, when you look at the median progression-free survival, it was not reached, and there's going to be updates at this upcoming ASCO meeting as well. And in fact, when you look at the patients who had a stringent CR, the 2-year PFS was almost 71%. The overall survival, again, median overall survival not reached. 74% of the patients were alive at 2 years, compared to, again, some of the control population that we have seen in other studies. So this is a real-world control comparison that was done with cilta-cel. And as you can see here, the CARTITUDE-1 study patients had a significantly better PFS and overall survival compared to the real-world cohort who were matched for the lines of therapy and other risk factors as was enrolled in the CARTITUDE trial. So again, at the absence of phase 3 trials, this is the best data that we have to compare these modalities with the standard of care. And hopefully with the phase 3 trials, we'll have better answers. CAR-T therapy is not without toxicities. Clearly, there's some things that we see fairly common, such as the cytokine release syndrome. Some things which are less common, like neurological toxicity, which is seen in less than 20% of patients. Then obviously, there is off-target effects like the profound hypogammaglobulinemia these patients have because of the B-cell aplasia as well as plasma cell depletion. That can lead to increased risk of infections. There are theoretical risk of insertional oncogenesis with the lentiviral vector, which necessitates long-term follow-up, which hopefully can be overcome by use of some of those newer technology like the transposon-based approaches. One of the biggest disadvantages of the autologous CAR-T cell is that you have to collect the cells, you have to manufacture the CAR-T, which can take up to 6 weeks. And in someone with relapsed refractory disease, that 6 weeks might be difficult. So in those settings, we can certainly consider allogeneic CAR-T cells. There are clinical trials that are ongoing. These are basically healthy donor T cells that have been, again, remanufactured or re-engineered the same way the autologous CAR-T cells have been, with the exception that here we also do some CD52 depletion or deletion because of the need to have a more profound lymphodepletion prior to the infusion. So obviously there are some advantages, some disadvantages. Obviously allogeneic CAR-T cells can be scaled up easier. It is off the shelf. You identify the patients, you can potentially get them a treatment within the week, unlike 4 to 6 weeks for the autologous CAR-T cells. There is theoretical risk of graft versus host disease. We haven't really seen that with any of the studies that we have done so far. And obviously there is the advantage of maybe even giving re-infusion here. CAR-T cells are not without limitations. Obviously, we talked about a lot of the studies so far have been in the relapsed refractory patient population, where sometimes a significant number of patients whom you enroll on the study may not actually get to the CAR-T infusion. Obviously, there are concerns and limitations to the production platforms that are being worked on. The current studies are looking at different ways of engineering the CAR-T cells, expanding them ex vivo, using more naive T cells from the donors and so forth. So toxicities are a lot more easier to manage. I think we have gotten more comfortable managing cytokine release syndrome. Clearly, the neurotoxicity is still of concern. But finally, I think, even though this appears to be quite promising, we are still seeing most of these patients relapsing. So the question is, what makes these CAR-T cells not work anymore? There is no universal mechanism. I think there are multiple different things that can be at work. One of them is antigen loss. We have seen examples where the myeloma cells have lost the BCMA expression. So dual targeting of the myeloma cells with the CAR-T may be one way to get over it. Immunosuppression is a problem. There are approaches trying to see if we can use PD1, PD-L1 blockade in association with the CAR-T cell to enhance the activity. We know that when T cells have received tonic signaling, they become anergic. So there are other approaches to see if we can design the T cell receptors better. And obviously the other immunological mechanisms as well. Now, when you think about all those problems with CAR-T cells, obviously we want, there's a lot of interest in trying to see if we can somehow use a different approach to redirect the CAR-T cells or the T cells. So one such approach has been the use of bispecific T cell engagers. It's a very simple but elegant approach. It's basically a bispecific antibody. One of the specificities is for CD3, which recognizes T cells. The other half is specific for a tumor-specific antigen of the initial ones being BCMA. So essentially, they bring the autologous T cells next to the myeloma cell, enhancing immunological synapse formation and tumor cell death. Now, there are multiple different, again, bispecific antibodies going through clinical trials. One of the earliest is teclistamab, which is a CD3 BCMA bispecific. You will be hearing some updated data from the Majestic trial at the ASCO this year. But again, from what we have seen so far among the first 150 patients or so, the overall response rate was about 62%, including a 28% CR rate. Again, quite impressive, maybe not quite the same as what we saw with the CAR-T cells, But advantages of this is obviously this can be used in a significantly larger number of patients. The responses do tend to deepen with time, and these therapies can be given for longer periods of time. In terms of side effects, it's very similar across all the bispecifics. The cytokine release syndrome is one of the commonest side effects, in almost 70%, but mostly grade 1 and rarely some grade 2s. But overall, the severity of cytokine release syndrome is a lot less compared to the CAR-T, and typically happens only with the first infusions or when there is a dose increase. We do see some hematological toxicity, particularly cytopenias, and we do see that with CAR-T as well. The mechanisms are not very well delineated, and some of these patients can take some time for the counts to recover. The other major thing that we need to continue to work on is the increased risk of infections. We don't understand all the mechanisms, whether it's related to these later stage patients who were profoundly immunosuppressed, or is it related to the profound hypogammaglobulinemia that these therapies tend to induce. Certainly, there are some opportunistic infections, including initial viral reactivations, which need to be kept in mind. Another BCMA-specific bispecific that is going through clinical trials is the ABBV-383. This is slightly different from the teclistamab. This is IV, but it can be given once every 3 weeks and appears to have a lot less of cytokine release syndrome compared to what we have seen with other BCMA-targeted bispecifics. Now, the responses are quite good. Overall response rate, especially at the 40 milligram or higher dose, appears to be about 81%, including VGPRs in about 70%. So clearly, these responses will also deepen with time. Now, BCMA is not the only target we can go after with this platform. There's another one, GPRC5D. This is the talquetamab. The initial studies, again, sub-Q dosing once every 2 weeks. Overall response rate about 70%, including patients with triple class refractory disease. So very comparable to what we have seen with the other bispecific agents, and the toxicity profile appears to be the same as well. Now, the GPRC5D is an antigen is of great interest. There's actually going to be one of the presentations at ASCO that's going to be looking at a GPRC5D targeting CAR T cell. Now, another antigen of interest is FcRH5 or CD300. This is cevostamab bispecific, very similar in construct. And what we have seen with cevostamab is, again, an overall response rate of about 60%. Again, it's very difficult to compare these different phase 1, phase 2 studies because of the heterogeneity of the patient population included. But nevertheless, I think what one can certainly be sure about is that, when you look at all these different T-cell engager therapies, you see a overall response rate of about 60 to 70% in a heavily pretreated patient population that's almost 60 to 80% triple class refractory. The CRS rate's about 60 to 80%, very easily managed, and neurotoxicity is relatively uncommon. Now, switching away from immunotherapy and going to the targeted agents, obviously we have data with venetoclax showing that this can be quite effective, particularly in patients with 11-14 translocation. The Bellini trial randomized patients to getting venetoclax with bortezomib dex versus bortezomib dexamethasone. The initial data showed that there was almost a doubling of the PFS with the addition of venetoclax in all patients. However, there was increased mortality amongst patients getting venetoclax in that initial trial, particularly early on during the first 6 months or so. So we have done a lot of subgroup analysis to better understand who is benefiting and who is being harmed. And when you look at patients who have, either 11-14 translocation or presence of high BCL2 by PCR, you can see that either one of these is associated with a significant benefit with the addition of the venetoclax to bortezomib dexamethasone, as you can see here. But if you look at just 11-14, you see significant benefit, significant p-value, hazard of 0.61. If you just look at the BCL2 high, it's 0.7. If you look at the people who are not 11-14, but just BCL2 high, you still see a benefit. So essentially, what we are seeing from the Bellini trial subgroup analysis is that as long as you have 11-14 translocation or a high levels of BCL2, venetoclax appears to help. If you have high risk markers, and particularly if you're low BCL2, then you certainly should not be using venetoclax in those patients. The other drug of interest is the iberdomide. Again, this belongs to a new class of drugs called CELMoDs. As you all know, lenalidomide and pomalidomide all work through degradation of ICROS and ILOs. And here, the CELMoDs are much more targeted in, again, targeting the cereblon, which is a E3 ligase, E3 ubiquitin ligase. And you can see that that leads to degradation of ICROS and ILOs, leading to myeloma cell death. Now, some of the early data that was presented by Dr. Loniel at the recent meeting demonstrates that iberdomide just used with dexamethasone can be quite effective both in patients who are refractory to an IMiD as well as patients who have progressed on prior BCMA targeted therapy, both of which are important subgroups of patients given the current treatment scenario. And here you can see that even in patients who are refractory to an IMiD or been seen an IMiD or a PI in the past, overall response rate of 26.2%. Patients who are post-BCMA, you still see an overall response of 25%. Ongoing trials are looking to see if there's an advantage of replacing lenalidomide or pomalidomide with iberdomide or the other CELMoDs that are being looked at in clinical trial. Dr. Nuka already talked about the role of salvage high-dose therapy. We won't go into that. But I think one of the areas of great interest going forward is, can we look at a more patient-specific approach? So my drug is a trial that we're doing currently that is looking at patients with functional high-risk disease, meaning early relapse after initial therapy, doing genomic profiling. And then based on the particular abnormality, they will get a targeted agent. For example, if you have a RAF or a RAS mutation, which can be seen in almost 55% of patients, then patients get a MEK inhibitor like cobimetinib, which is then followed by addition of ixazomib, pomalidomide, and dexamethasone, and so forth. But I think this is, in the future, I think we will be using immunotherapies more often, probably earlier in the course of therapy, to get deeper responses that are probably longer lasting. But unless we are curing a significant number of patients, many of these patients will need additional therapies. And that's potentially where we can incorporate some of these patient-specific approaches. So clearly, we have seen therapeutic advances that have led to increased survival, but it still remains a chronic disease. And the overall treatment really needs to look at a long-term strategy. And the key is delivering the best package of treatment at a given stage, whether it be newly diagnosed disease, as Dr. Loniel talked about, or early relapse, as Dr. Nuka talked about, or in the later stage, as we talked about with all these newer therapies. So hopefully the future approaches will allow more individualized treatment of patients with myeloma. With that, I'll stop share and take any questions that you have. All right. I have one question here about the therapeutic landscape of myeloma in future. I think it's difficult to predict, and I'd love to hear what Ajay has to say as well here. But I suspect we're going to see some of these immune approaches much earlier on. My guess would be 5 years from now, we'll have one of those bispecific drugs with a monoclonal and anti-CD38 monoclonal antibody and immunomodulated drug combination in the initial treatment setting. And that hopefully with or without transplant will allow a very deep response in the majority of the patients with myeloma. And those patients, the standard risk patients in particular, I think we will be able to give a limited duration of therapy and then have patients get treatment-free intervals that might last for years. At the time of the relapse, in those patients who are not cured, we will have to look at other drug classes and novel agents to make combinations to try and treat those. Ajay, I don't know if you want to add anything else there. The crystal ball.
I cannot agree more. So I think these T-cell redirecting therapies probably would be more beneficial when in a newly diagnosed patient or earlier on, where there are more healthy T cells than in the later lines of therapy. So if you're able to show such good activity as later lines of therapy in these heavily refractory patient population, there is no reason for us to think otherwise. So I completely agree with you.
Great. Will iberdomide replace lenalidomide or pomalidomide? I think it's a very valid question. I think that's what the clinical trial seems to be looking at, is to see if we can actually get more deeper responses and better activity in combination with the current combinations that uses len. Again, the toxicity profiles are very similar, maybe a little bit more cytopenias that might, make some difference as to which combinations where it might be better than the LEN. Other thoughts, questions? I will just open up. I don't see anything else in the chat box. Dr. Jena, I'll hand it back to you.
Okay, I think there was a question, even I repeated, there was a question from Dr. Trivikram Panda, how to handle MGUS related neuropathy, symptomatic neuropathy.
That's always challenging, because obviously all these patients whom we see with a peripheral neuropathy and a MGUS, obviously, the key thing is making that association, right? Somebody with an IgM MGUS and a neuropathy, especially in the presence of MAG antibodies, is pretty straightforward. I think we need to look at the type of neuropathy. Generally, these MGUS-associated neuropathies tend to be peripheral, length-dependent neuropathies. So that's obviously one thing. Obviously, there are certain conditions like POEMs, obviously, has a different constellation of findings, and we want to make sure that we are not dealing with that, because there the relationship is very clear and we can treat them. The other patients, I think we really need to take into account other, do a very thorough workup to rule out any other reasons for peripheral neuropathy. And if somebody has stable neuropathy that is not limiting their activities, I would not necessarily treat them then, watch them closely. But if they have progressive neuropathy, we may have to bite the bullet and do something. And those patients, I think I would try to give them, again, a combination that we know is effective, preferably right now with the monoclonal antibody daratumumab Lendex combination, we could consider using that or just using Len alone. The biggest trouble is if you completely eradicate the M spike and the neuropathy doesn't improve, you may be, maybe you come to the conclusion maybe they were not related. But more often than not, what we end up with is a partial reduction in the M spike and in neuropathies that may not improve, and which leaves us better shape, because we don't really know if they were related or not. So quite challenging for sure. Ajay, your thoughts?
You covered every aspect, Shaji. I think the Waldenstrom's patients are the ones where that's the other piece where it takes much longer. The natural history of the progression needs to be monitored very closely. And I think if they're not fitting the picture, I completely agree with not doing anything, rather than observation probably should be the goal of treatment, unless you're finding a target.
Perfect. All right. Dr. Jena, back to you.
I think we come to an end since there's no question. We enjoyed, and on behalf of Indian College of Hematology, I will always extend our deepest appreciation and sincere thanks to you, Dr. and all the faculties like Dr. Vincent, Dr. Sagar, and Dr. Ajay, sparing your valuable time and a very difficult time, early morning around 6 to 7 a.m., that too on Sunday, and educating us. You have been immensely benefited. And thank you very much for your really help and cooperation and contribution. I also thank all the participants who have joined in a very big number and participated very actively with good questions and interactions, and making this myeloma CME very fruitful and educative. With this, we'll come to an end, and thank you very much, all of you.
Thank you. Good seeing everyone. Take care. Bye, Ajay.
Rewarded people also. Rewarded people has done a wonderful job so far. The technicality is concerned, absolutely flawless virtual meeting. Thanks to Rewarded also. Thank you all of you.